Good morning, everybody. My name is Ciara Rochford. I'm the Director of the Regional Centre for Nursing and Midwifery Education here in the South East. I feel a bit silly introducing myself because actually I think I know absolutely everybody in the room. So it's lovely to welcome you all here this morning to today's NMBI Series. So we're delighted here in the CNME South East to be invited to co-host the first of 4 NMBI Series nationally this year. It's wonderful to see so many colleagues from across the region attending the session today, and I want to thank you all sincerely for making the effort to travel today. We know how busy your schedules are, so the fact that you've turned out in such huge numbers is so reassuring to us as a centre, and I'm sure to NMBI as well, that the level of interest is out there. So thank you very much. Your attendance is very much appreciated. I hope that you enjoyed the event today. And I am not going to speak anymore. It was just to welcome our local colleagues today, and I'm going to hand you over to Dr. Louise McBride, President of NMBI.
So good morning, everybody, and thank you for this very warm welcome and such a fantastic turnout, because we all know how busy Practice is, regardless of what role you're in. So this is Partnership and Practice, the theme of the autumn, first of 4 to get us off the blocks in the sunny southeast. And thank you all for the invitation, for the fantastic organisation, but most of all, whoever put out the Child of Prague, because the sun was shining on us for the last 24 hours or so, and keep it for the rest of the week because we have to go down to Kerry. So as Ciara has alluded to, this is the first of 4 events today in Waterford. We're in Kerry later on, and then in the week, and then we will be in Galway and in Dundalk later in November. It's important to note that this is a follow-on from the inaugural summer series that was co-hosted with NMBI and the higher education institutions last summer. And as a response and as, I suppose, feedback, it was very much to the fore that it was a successful event. So we felt it very important that we would bring it back to the different locations nationally throughout the provinces of Ireland, but more importantly, make it accessible for people to attend, because we do know how difficult travel is in getting away. So the ethos of this is to build on that open conversation dialogue. It's not about the board or Roisin or anybody else coming to talk to you. It's about stakeholder engagement, it's about stakeholder networking, but most of all, it's about actually listening to the voice of our registrants, our nurses, our midwives, and the different stakeholders and the different roles that you fulfil. So the theme is very much about partnership in practice, and if you look at what the board or the regulatory body is all about public protection, but the pillars of what we do is about regulation. It's about registration, but most importantly, it's about education and training, because the profile of nursing and midwifery does need a huge injection of motivation and stimulation. I think we'll all agree as we go around and listen to the speakers. So out of that theme, we have developed the speakers this morning. So my role is not just to welcome you all, but to give you an overview. So Roisin will talk about the opportunities for our nurses and our midwives in the context of education, continuing professional development, because there's no point in us putting out graduates time after time, not retaining them and not fostering and nurturing them, but most importantly, not keeping them within our profession. So then we will have Carolyn and Kate, who will talk around the whole area of mental health and wellbeing. And this was specific feedback that we got from last year as an evolving theme and narrative that keeps on coming up. Self-care, mindfulness, looking after each other, looking after self, reflective practice. And I think we have to go back to those core fundamentals again, because it is very busy out there. And it's no different in teaching, and it's no different in the guards, but we are the regulation of nurses and midwives. So we need to listen to what our registrants have to say and how we can actually enhance and improve things on the ground. So as the newly appointed Vice President, I would have been appointed as the higher education appointment several years ago by the Minister. I was Vice President for some time and now I'm the President. And very much my mandate when I came into office was about the optics of the regulator and it being very Dublin-centric. So having worked and lived in Dublin and trained in the matter and worked in higher education, I was very much conscious of the importance of moving away from the northeast and Dublin and coming out regionally from a network point of view and meeting the registrants within their hubs, within their localities, and actually bringing rather the mountain to Muhammad the other way round. So I think we're doing a good job in the context of that. So this is an opportunity to look at, you know, what's available, what developments are there, the state of the register, and we will also be looking at fitness to practice, which is always of interest to every registrant, regardless of what discipline. So I just want to draw your attention to the schedule, and again to congratulate Kira and her fantastic team for bringing together such an exciting schedule. We've a huge array. I was just talking to her before I came in. We've representation of every discipline, of every role, be it from Director of Nursing, Assistant Directors, clinical nurse specialist, clinical midwifery, advanced practice, practice development, CPCs, SALOs, and there's a student registered. Is she in the room? She might be on her way, because the students are our future. They are, you know, and I'm speaking for myself, they are the one that's going to be patient-facing me when I end up in hospital. So the importance of nurturing our students is very, very important, regardless of whether they're undergraduate or postgraduate. And I think we've some work to do on that, because as we know, there is currently quite a lot of our new grads who are emigrating and going further afield. So if you're to take a screenshot of the CAO, and my full-time job is in academia in Donegal as head of department, you know, 6 out of 10 CAO students got their first choice in the Leaving Cert. Anybody here with Leaving Cert students in the house? Yeah, a few. So probably all very happy. We increased our places 259 in higher education. We've increased 200 in Northern Ireland. We are not filling first round offers, and I think it's a concern and it's something we all need to grasp and we all need to be very mindful of. How do we promote young Leaving Cert students or further education and mature into the profession of nursing and midwifery? More importantly, how do we retain our graduates? And most importantly, how do we actually support our staff on the ground? So we've all, as a profession, individually and collectively as stakeholders, but more importantly as the regulator, to hear how we can actually enhance the profession and actually bring in more, because I think there is quite a lot of work to be done there. So I could talk for Ireland, being in higher education, so I'm going to move on, but just to draw your attention to a couple of things is that this first session after the welcome, I'm going to introduce Cathy Ann Barrett, who's the Director of Operations in NMBI, and Cathy's going to give us an overview of the state of register. For the first time ever now, we have live stats of the state of our register, which is absolutely phenomenal in terms of workforce planning and planning for the future. That's going to be followed by a question and answer session around 9:30. I know we're a little bit behind schedule, and Sheila is going to facilitate that, our CEO, and that's followed then by a session whereby Roisin is going to give us an overview in her new, and congratulations to Roisin in her new role as the education lead for the ONMSD, and she's going to give an overview of opportunities from a postgraduate point of view and a continuing professional end. Then we'll have another session for questions and answers, and then set your clock, 11 o'clock for the coffee pickup, and then followed on by our health and wellbeing session by Carolyn and Kate, and we're also then going to have a session on fitness to practice. So I want you all to now, you know, for the next couple of seconds, just leave whatever is in your head down and just try and concentrate and really engage and take the most out of this morning and your time away, and not be worrying about rosters and not be worrying about who's collecting the kids and not be worrying about how they're going to manage. just decommission and just sit back, relax and absorb. And I really hope you get something from today, whether it's in each of the sessions or whether it's in one particular session. So without further ado, I'm now going to hand over to Miss Kathy Ann Barrett. Thank you.
Morning, everybody. Just bear with me for a second just while I get this sorted. Sinead, you might. So just while Sinead gets that moving for me, hopefully. Good morning, everybody. As Louise said, I'm Kathy Ann Barrett. I'm the Head of Operations with NMBI. And what we wanted to do at the outset this morning is just to give you a snapshot of the state of the register. So Louise talked about the 3 pillars of NMBI, and one of them is registration. And as you know, everybody here in the room will know that everybody here in the room will probably be very familiar with the registration process that you have to go through yourself or your colleagues do, and then your annual renewal process. So as part of that annual renewal, now we're able to gather really valuable information about the nursing and midwifery professions and the workforce that's out there. So as you know, the annual renewal window opens every year around October and continues until February. And as part of that process, we ask questions about whether you're practicing, whether you're patient-facing, and where you're practicing and patient-facing. So, as I said, my session is short enough this morning, and it's just to inform the rest of the discussion for today and just to give you a snapshot. As Louise said, we haven't yet published these statistics. We won't be doing that till October. So you're getting the very first snapshot of all of this. And as this is the first event of the series, you're getting the very, very first snapshot of our statistics. So just to give you a quick idea, and again, Louise touched on this already, of who we are. As you know, many of you in the room would be very familiar with NMBI, but in case you're not, we're the regulator for the professions of nursing and midwifery. And we perform our functions under the legislation, particularly the Nurse and Midwives Act 2011, and to protect the public and to support the professions and promote the professions. If you want to read more about our values and our vision and our mission, we just put together a new statement of strategy for 2023 to 25, and that's available on our website at the moment. So if you want to look into that in any more detail, that's where you'll find it. So the state of the register. So as I said, it tells us how many nurses and midwives are registered, practicing and patient-facing in Ireland. It's been possible since we digitised our registration, as you'll be familiar with, as I said, the annual renewal, to gather that information and now to analyse it. And we published it publicly for the first time last October, and we're going to publish it annually every year. And what we do is we take, as you know, or as you might be familiar with, the register will change over time. So there'll be people added. There's the annual renewal, but there's also people regularly added. It'll be the new graduates, September, October time, and then throughout the year, our colleagues who come in from overseas will be added to the register. So it changes, but we had to take a moment in time, so we've taken the 1st of June. So every year on the 1st of June, we'll pull all the statistics from the register and we'll compile them and put them together. And as time goes on, we'll be able to compare and get some richer analysis. But last year was the first time that we published those. Just to note, so the overall figures are the figures, but in relation to whether people are practicing, whether they're patient-facing, the counties that they work in, that's all self-declared. So we rely on what people tell us. So that's self-declared. And as I say, it was last published in October last year, and we'll be publishing it again in October this year. So we have still work to do on the statistics, but we wanted to give you a first look at it. So as and from the 1st of June 2023, there are 84,948 registrants on the NMBI register. So that's up. I'll show you comparisons in the next slide, but that's up from 81,431 last year. 79,500 of those are currently practicing, and 6,200 new registrants. And that means obviously that 5,400 are not currently practicing. Patient facing then, we ask people, are you patient facing? And that's 70,969 this year. So just to look at the comparison then to last year, and as I said, this is the first year that we've been able to do this, get a like-for-like comparison, and this is where we'll really start to see the data adding value to workforce planning in particular, because we'll be able to compare it year on year. So there's a slight jump in all the categories. We have a 4% jump in the register overall, so it's gone from 81,400 to 84,900. Practicing is gone from 72,800 to 79,400. So that's the biggest jump. We have a 9% jump in practicing. So we're looking into that at the moment, and we're kind of analysing those figures. As I said, it's self-declared. So when we were discussing this last night, you know, why is that jump bigger than the actual jump on the register itself? Are more people practicing? Are more people declaring that they're practicing? Have you had some people retiring? So we look into some people retiring who were not practicing, so we'll look into the statistics a bit more on that. And then patient facing, it's jumped from 66,400 to 70,900, so that's an increase of 6.7%. So again, that's a greater increase than the register itself. In relation to the gender breakdown, this hasn't changed much since last year, and you won't be surprised. This is what you see in your day-to-day lives. Again, it's a predominantly female profession, so 90% and 10%, and 3 people prefer not to say. Age distribution of all current registrants. Again, this is very similar to last year, and what you would, I suppose, expect to see as a profession. Relatively low number on the 2024, and then it kind of goes up to peak at 30 to 34, and then again you have a bit of a drop from 40 to 44. It's the, you know, we've done the slide before, it's very much female profession, so you have a little bit of a drop there, and then you have it increased to 11 and then back down 65 plus, and there are 2,900 people on the register in the 65 plus age group. So this is the age distribution of the practicing registrants among those. Again, it's pretty similar distribution to the register itself, as you'll see, but it kind of, the 30 to 34 and 35 to 39, you'll see those are the peak numbers. And then this is patient facing. So again, pretty similar distribution to the slide before. This is the age distribution. So this is the comparisons then that you'll see. And so you can see there all registrants practicing and patient facing. This is the age distribution of overseas applications submitted 2022 to 2023. We thought this might be interesting to look at from a workforce planning perspective. So you see the largest category there again is the 30 to 34 group, and second after that is the 25 to 29 group, and it drops considerably then for the 45 to 49 group. So that's, I think, would be interesting for people recruiting in and looking at that from an age profile perspective. Geographical distribution. So we ask people not where you live, but where do you work? And again, this is self-declared, and it's on a county basis as opposed to a particular hospital or CHO. So this is the distribution around the country. Again, it's the main urban centres. They're the bigger ones, as you would kind of expect. You'll see Waterford down there represented, and then around the Midlands you have small enough numbers, as you'll see there around the Midlands. Obviously, the biggest concentration is in Dublin, and then Cork, Galway, Limerick is represented well as is Waterford. Now, this is one that we wanted to show you today, because again, it will feed into the discussion that Louise started at the outset. So CCPS applications. So for those of you maybe not familiar with those, it's the Certificate of Current Professional Standards. So if you are a nurse or midwife and you're on our register and you want to practice abroad, you have to apply to us for a CCPS. And we grant you that, and then you use that to go on the register of another jurisdiction. This is the number of applications we're getting for those CCPSs. Now, it's important to say that this is not a definite ticket. This is not a definite move abroad, but it's definitely an indication of intent. And the important thing to see as well is that it could be several, so it doesn't necessarily represent individuals. So somebody could apply several times, so they could be considering to move to Australia and then it could lapse, so they need an up-to-date CCPS. But the increase is very visible and it's there very clearly to see. So as you see, if you look at May, which is the last month that we have figures for, it's 200 versus 480. Isn't it 480? Yeah, 480. So that's a trend that we're definitely watching very closely. We're discussing a lot at board level. We're discussing with the department, with the ONMSD, and I'm sure it's something that'll feed into our discussions here today because it's something that we have to watch. And then this is the age profile of CCPS applications 2021 to 22. So this is just to give, this is not the 23 figures now, but this is just to give, again, a little bit of context for our discussion. These are the people who are looking for the CCPS applications from us. Not surprising that that kind of 30 to 34 is the highest category there in the middle. So this is just a quick snapshot of the divisions. There'll be a lot more detail on all of this when we publish the state of the register, but this is an overview you might be particularly interested in. As you know, we have divisions, and this is how it breaks down in relation to registered practicing, patient-facing for the different divisions, and there you'll see the increases. For those of you who are good at your maths, you'll notice that the figure on the bottom is higher than the overall register, but that's because you can be on a number of divisions at the same time. So that will be of interest to people if you're working in particular divisions within the register. But there'll be a lot more detail, and what we will do in the state of the register is we'll break down each division on its own chapter and go through the increases or the changes in each division. So that's it from me. So that's the overall kind of snapshot of where we are right now. As I said, we'll have a lot more details in October, and I hope that there's some information there for discussion. Sheila, I think, is going to take your questions.
Yes, well, I'm going to take the questions and then I'm going to deflect them to Cathy Ann. So, but yeah, you can see from, as Cathy Ann has clearly said, and so has Louise, I mean, we've only started to collect this information in a way that we can report it. We do collect as much as we can under statute. There's been a debate about that, about how much more we can ask for. What this doesn't, I suppose, tell you is, and what we probably are thinking about is, we don't know from those stats who's working full-time, part-time, so there's a slight lag in if we're looking at that purely as resource deployment. But it is really, really good, and of course the HSE as a main employer is very interested in it, and you can see some of the policies of the HSE in relation to AMPs, and AMPs are a significant increase, net increase in the register, so you can actually begin to see some of this coming into fruition. But, you know, I know it's a lot of information for you to take in, but are there any questions that you want to put to us or further stress test the veracity of this information? Because we stress tested ourselves internally, but it's very good to hear things that jump out at you. So there are going to, there's roving mics here, and it would be great whenever you speak if you could just say from, you know, where you, what your name is and where you work.
Don't be shy.
Yeah.
Sorry. Can you hear me?
Yes.
I'm Nora Sheehan, I work in occupational health.
Mm-hmm.
And you were saying that there was a big increase in CCPS applications, but you're comparing COVID here.
Yeah.
You know, have you any figures pre-COVID? Because that figure, that huge dramatic increase from last year to this year, probably pre-COVID would have been around the same?
So, no. No, this is significant step change this year. And we think there's international, we're involved internationally, and we think there's international reasons for that. That America has clearly opened up for recruitment, and they're discovering that before in the North American region, they were fighting with each other about nurses, diminishing standards across boundaries, across state boundaries. And that has totally changed to realise that they can't actually resource their health service just from internal. So they've now reached out and they've become much more competitive internationally. So we believe that there are big packages being offered, and people are either not coming to Ireland at all now, because we're seeing even a reduction in the applications that are wanting to come, but also people are leaving. And we also then believe, from the interpretation of what we can see, and what Cathy Ann alluded to, was that sometimes they're applying for two, so they're maybe going to the States, getting the benefits of that, and then bouncing on to Australia. And you can also see that the profile of people that are coming in are exactly the same as the profile of people that are leaving. So, you know, people come to Ireland because they're attracted, because they're recruited, but they are relatively transient because they don't have roots. And then, you know, they move on to somewhere else which is offering them a better package. So this is what we're beginning to see. So this is why there's a real requirement for us all to get into the space of thinking how we can make the job in Ireland and the professions in Ireland a long-term success for both the Irish trained and the newcomers. And we're also finding that some people, especially we're saying Filipinos, are actually have been here for quite a long time and are now returning to the Philippines in retirement. So they've done their 20-25 years in the service here. So there's a lot of reasons why we're seeing movement. Now obviously it is, you know, it's a superficial take on it, and we don't absolutely know those people will move. But you know, it is a concern for us, and we have voiced that up into the department.
Thank you.
Okay.
My question's answered. It was mostly about the international part, that they are also going through the CCPS, because I think we're starting to see now a pathway out after 2 years.
Yes.
That started.
Yeah. And it's how we, you know, can get behind that and think what's causing that. But we do think it's international incentives, if you like, that all of a sudden the world's becoming much more, we're competing with each other, and we go internationally and tell them all to mind their business and leave us alone and stop robbing our resources, but it doesn't seem to be working.
And I think when we're in the situation where we don't have safer staffing implemented throughout the system and throughout all specialties, we do have people working in conditions that they would have better conditions abroad. I think that's quite big, particularly for Irish nurses.
Or appears to be better, maybe when they get there.
Appears to be better.
Yeah, the other thing that maybe is masked in this is that there was a huge, and continues to be a huge recruitment drive in the HSE and beyond in last year, and we were really, really busy taking in and processing applications, and that was identified about the application levels. So they were significantly up on the year before. So the net increase, you know, is actually a real increase in that you have people obviously leaving who are not practicing, or certainly they're not going up in numbers, whereas the numbers you're seeing, the significant increase in practicing and patient facing is, I would say, as a direct result of the increased manpower investment in the HSE. Because I think some of the figures are like, in 2019 there were 39,000 nurses, and by the end of 2022 there were something like 46,000 nurses in the HSE. So there has a lot of this increase has been driven by the HSE recruitment drives that we are then part of a process in. Anything further?
Hi, I'm Chi from Wexford General. I just wanted to see a representation of the internationally trained nurse and midwives who were registered within the period of, especially post-COVID or during COVID, and also the CCPS graphic representation of people, just to check the retention levels, really.
Yeah, and if you know, we need to ask the audience, but we have a slide on that. We can get the figures before the end of the day. So there was a significant increase last year, step change in the amount of overseas that were registered. But so there's a lag. So they're what we call it, people apply and then they get processed to a certain point and get decision letters, and they can come to Ireland, and then they do a final stint, an adaptation period or an aptitude test, and then they become registered. So the figures all don't correlate. So we had a significant increase in applications last year. They haven't turned, altogether haven't turned into registrations. And that's probably because of the issues in other departments with the atypical working visa. There are delays there. But we do hope that they do transfer into actual registrations. But there was a significant, even if you just look at registrations, last year was the highest level of overseas registrations we've ever had. Certainly in proportion to then the Irish train, because obviously you're stuck with whatever went in minus 4 years ago. In the COVID crisis, people applied but then got stuck, couldn't get to Ireland to finish that last bit of the process. So we can give you those stats over the last 2 or 3 years. We'll find those for you before the end of the day. But there is a significant, last year was the most positive by way of registrations, certainly the most positive by the way of applications, which should turn into registrations in the longer term. But there is also then the flip side of that, which is it's now overseas that are looking to get CCPSs that look as if they might be wanting to leave. Now, not in the same quantity, but in a concerning volume. But we'll get you those figures before the end of the day.
Thank you.
Okay. Somebody else? Yeah. Oh, yeah. Sorry, this guy. I'm afraid I think he looks like a union. So I'm worried about him.
Good morning. My name is TJ White, Director of Nursing and Midwifery
Oh, right, okay.
University Hospital. Good morning. Thanks to everybody for coming down. We do appreciate you coming down to the sunny southeast.
Great.
This is just more of my thinking rather than actually a question perhaps, but when we look at international recruitment, it is essential. Based upon, I'm in post for quite a while. If we didn't have international recruitment, we wouldn't have a workforce. The onus is on us in order to retain that workforce. They have been a superb addition to our workforce. They're always going to be required. We've made it very difficult to get into this country, particularly with the red tape element of Garda vetting, these applications, bringing family over, it's incredibly difficult for some of our staff to settle within Ireland. Therefore, sometimes we do actually drive them out of the country. When we talk about retaining staff, we look at our exit interviews, and it doesn't come down to money. It comes down to nurse-patient ratio. It comes down to the ability to progress within the service education. So money isn't the main key. However, if I can just bring it back to when we look at we've done significant work, and my thanks to everybody for that in regarding to our senior enhanced nurse pay grades, etc. But our CNM grades has to be addressed. It's caught up in the national talks at the minute.
Yeah.
That is going to be there for years. We have to action on that, because we have seen from my colleagues throughout the country who I talk to, we have posts left unfilled at CNM grade because it is not attractive. It's not financially attractive to them to move into that paper.
Yeah.
We do need to look at expanding our undergraduate and looking at alternative solutions to international recruitment. For my service, it accounts for approximately between 70 to 80% of my recruitment. When I took over nearly 9 years ago, it was my international population of nurses was 2%. Now it's nearly 50%. So we have to look at solutions other than international recruitment, and that maybe we have to look at our HCA elements. How do we progress them forward? I know in the southern half of the country, perhaps only 6 or 9 actually progressed to undergraduate studies this year. HPAT elements, perhaps we need to look at something along that line as well. But international recruitment is very important to us, but it cannot be our primary route of educating nurses in this country. And just going back to when I trained, I'm a bit old, so every 6 months we had an intake of students. Perhaps we need to look back at that from the functionality within an organisation of an acute hospital. It would work very, very well, a 6-monthly structure, because the glut of students when they come out proves very difficult for them and also for the acute hospital board. So that's just some of my thoughts and questions. Thank you.
Okay. Yeah, you come in. Yeah, because you're totally talking to Louise's mandate here.
You must have got the mandate. PJ, is it? TJ. In terms of alternative routes, you're absolutely right. There is an initiative happening in Atlantic Technological University, thanks to Simon Harris, our Minister for Higher Education, to look at this, because we know that further education level 5s, it's a lottery ticket. So that is in the wheels are in motion. There'll be a new cohort starting in September of this year that will transfer seamlessly into the 3 Atlantic Technology, Sligo, Mayo and Donegal. We think that will be the start of something to come in terms of it piloting. Now I know the SALOs and placement officers and my counterpart, if anybody here, I know Sarah isn't here, Sarah Kennedy from the local university, talking and cringing twice a year, but you're right, we have to take the blinkers off. They do it in Northern Ireland, they take them in twice a year, they take them in autumn, they take them in spring, and we don't have the bottleneck then of getting them all out in one academic year. So it is about shifting, it is about futures thinking, and it's definitely about foolproofing alternative routes. We have healthcare assistants who would make excellent nurses. We have to find funding and we have to find bursaries to support them and to secure a trajectory for them into nursing. We've been abroad, we've looked at what is happening international, and from an Australian and an American point of view, there is the assistant nurse. And it is a step down from the registered nurse. So you're probably familiar with the enrolled nurse from the UK. So it's an up-styling of that role with a different set of scope, practice, responsibilities, but it is another layer in between the very, very exhausted registered nurse who's the degree nurse. So absolutely, the assistant nurse, the bursary, we've recently launched just over the summer the graduate entry. Yes, it's at a level 8, which a lot of people might have felt that it should have been a level 9, but we have to get it off the blocks and we have to start somewhere. So there's lots of initiatives, but they're probably happening in pockets, and I think it's your observation and the dialogue that you've just shared with us, that we need to actually embrace and bring it back and put it on the agenda. So there are things happening, but there could be definitely a lot more. And I think everybody here who's patient facing, whether they're a registered nurse, midwife, ADON, CNM, you'll have healthcare assistants that you'll say, Mary, you'd make a fantastic nurse. John, you would be a great mental health nurse. So why aren't we nurturing them into the profession? So definitely, more has to be done, definitely. And that's one of my soapboxes, of course.
And just to give you the numbers, so Louise said 200 were acquired from Northern Ireland because they have a funding shortfall, and we were able to take up 200. Minister Donnelly wanted 400 net increased places, so there's now 259 extra capacity in the Republic of Ireland. But as Louise said, we have to find the people that are wanting to take up. We've actually seen a total deterioration now in the interest in nursing in their first choices, in the way we judge it. So, and that's not just Ireland, that's the UK is suffering exactly the same. So we must talk the profession up, we must promote it, and we must advocate for it in a way that encourages people who might consider it as one of their career choices to become the optimal career choice, and then when the capacity is there, we'll be able to fill that. So that's another element to it as well. Now, there's this girl here, and then there was somebody at the front.
I'm Emer Lodge. I work in Set2 here in Waterford, but I have just come out of clinical practice as an advanced practitioner for a number of years. I was just thinking your numbers for registration in 2024 were quite low, and I'm wondering where, if they qualify at 22 or 23, then where are those 2 years where they're to be staying in Ireland, getting their craft, their skills up and their confidence, and then thinking they might go and travel. We seem to be missing those 2 years of, opportunity to keep our young nurses with us, and I'm wondering how we can make that better for them. Whether it's a career progression, give them 18 months of, surgical, medical, maybe an acute setting experience, something to hold them here for at least 18 months, so that they get their confidence, consolidate their learning, and then okay, it's good to go and travel, it's good to see the world, and it's good to come back then, because it is a beautiful place to live in Ireland. You know, we have a great workforce, and it's lovely to work here, but we need to hold on to those couple of years, because that's what we're putting our money into. That's our education system at the moment. I don't know what you think of that.
It's an excellent point, and the graduate entry survey that was conducted by the HSE last year, the feedback from the graduates were they were finishing their internship at the end of May and they didn't have an offer of a contract, whether it was temporary, short time or permanent, and they knew there were jobs in the post. They also had indicated they wanted to stay in surgical, but they were told you'll be going to medical. They also said that they had an interest in going down the pathway of clinical specialism, or they wanted to work in A&E because that was the trajectory. There's no jobs there. So unless we actually respond to what their needs are, they're not actually going to stay. So the direct feedback from that graduate survey 2 years ago put a shining light on the HSE and our directors of nursing. Well, why aren't you actually offering them? So we have seen, I've seen definitely in the Northwest, a huge shift in my graduates before they finish saying, oh, I've been offered a contract to Christmas, or it's temporary, but you know, I have to relocate. So there is a change there, but it's through surveys and the state of the register that we can bring back these statistics. So they're very simplistic approaches, offering them a contract before they leave, leaving them or moving them to an area that they want to enhance their career trajectory, but most importantly, making sure they're going to be funded to do a postgrad in diabetes or epilepsy or neonates or, you know, CBT, whatever it might be, because there's no point in trying to put a round peg into a square hole or vice versa. So there are a couple of initiatives that we really need to try and invest, not when they're pinned and they're applying to emigrate, but certainly before they actually finish their internship. And if there is directors of nursing in the system that, you know, it's pushing, you know, to get those contracts, because they do want to stay after they graduate. And if we can hold on to them after they stay, we have a better chance of actually holding on to them there and beyond, you know. So that's just the graduate survey.
Yeah.
I'm Judy Ryan, I'm the Director of the Nursing Midwifery Planning and Development Unit in the South East, so you're very welcome. Just to say in relation to the sponsorship scheme for public health service employees of the healthcare assistants that you spoke about, we coordinate that nationally through the South East, and as TJ said, there's 9 places available for the South East, and that's across all areas of nursing midwifery. So we've been really lobbying hard for those numbers to be increased, because although the financial outlay might be an expensive scheme to run initially, you don't have any recruitment costs, you don't have any accommodation costs, you have none of that. These are people who are experienced. And we did look back at our data from 2017, and of the 250 people who we supported on the programme, everybody finished, and they passed successfully, and they stayed in service with the exception of maybe 2 people to fulfil the contract. So it's, you know, it makes total sense to increase those numbers. So we've looked within the estimates process, but it doesn't mean we'll get it, to increase the numbers from 30 to 60.
Yeah.
For next year, but we will stay lobbying hard because we see the success of that programme. And just in relation to the post-registration education funding, that funding is available through the ONMSD for nurses once they're a year in practice, so it's not prohibitive from our perspective. They're entitled to it, so we do fund programmes that are relevant to their area of practice.
I think a lot of that funding though is only if they're NMBI accredited programs.
No, because there's such a wealth of programs now, you know, in leadership or whatever. So we get that is NMBI programs are automatically funded, but we fund lots of programs, very wide range of programs.
And just to follow up on what Judy said, I mean, again, the unions are very clear about advocating for more sponsorship capacity. So, you know, there are a lot of people behind that initiative and say that there's great traction with it, that you get the people that are supported through the programme and they all are more or less retained in service. So it's, from that perspective, it's really great. And the other thing that we've been thinking about sort of laterally is, can we come up with MOUs or partnership agreements or whatever with Australian employment locations, because if people are going to go it would be better to have some sort of a rotation that we're sure they're coming back, or we have a promise to come back, or we have some Australians coming to Ireland. So we have to think imaginatively about if they're going to go. We have to find a way to make it attractive for them to come back, or there being some incentive so they're on a career break or whatever. So, but with the intention that they will come back. Meanwhile, we might get some Australian nurses to come to Ireland. So, literally, there's no bad ideas here, because we literally need to be thinking on our feet all the time about how to make Ireland more attractive. This is my last question. We'll know this lady at the back, Carol, and then you.
Just to carry on with that, have you looked at numbers of people who have come back from abroad? Irish people who've come back?
Well, we do, yeah, we do.
Like, for those people.
Yeah, well, I mean, again, we do have to be careful about how much we research, because we haven't really got the mandate to research. So we have to try and identify them, and and get them to voluntarily contribute to surveys. So this is part of what I'm saying. It seems a bit technical, but we only have power to collect the data we have, and we don't really have the power to pursue people further than that, even if we do think that they are somebody that has returned. So if somebody has stayed on the registry, see that we don't really know, they can still register from abroad. They don't really have to put in their place of employment, so we don't know where they are. So it's quite hard to track them, and our system wouldn't be that sophisticated just yet, but obviously we're going into a new generation of that, so it'll become better and more able to track movement. But then it's like, have we the powers to actually question those people? And we'll look to the Minister, and Georgina's here to hear all this, we'll look to the Minister to get those powers, just to make sure that we're not curbing people's civil liberties by pursuing them, because they've either gone to Australia or come back. Carolyn, this is the last word, because I'm under pressure. Dee's glaring at me.
Hi, Carolyn Donoghue from the Education Department in NMBI. I suppose just to throw some ideas out there in relation to different ways of getting people into nursing. Currently, we have our 4-year degree. We're all very wedded to that, and I absolutely think that's the way to go. But as Louise has alluded to, there's a lot of people who are in the further education realm, doing healthcare support, healthcare skills, pre-nursing, all of these things. So at the moment, they're all doing a level 5, 1 year. Do they want to go into nursing where they can become a healthcare assistant? So I think what we need to do is start thinking about the value of recognition of prior learning. So we're doing a lot of work within the board at the moment with the further education authorities and higher education, looking at if you've learned something, you should be credited for it and you don't need to relearn it. So we've got these people who are doing a year in pre-nursing, and they come out with 12 distinctions. You only need 5 to get into the lottery for the CAO. And they come out with 12 distinctions. They've done a year of study where they've proven themselves. They are really interested. They've gone and done their placement. They've still come back. They've enjoyed their placement, and they went, yeah, actually, that's for me. I can cope with that type of work, and I see that they work nights and weekends and all of these realities that is nursing and midwifery. But then we make them go into first year, because they have to do their full 4-year degree. So something that we are looking to try and explore is, can we have maybe a common first year across kind of nationally for a first year of a degree, so that all of the satellite places, where, as we say, people live locally, they have their accommodation, they have the parents there, or they have whatever their support structures, they have their kids in school, whatever part of life they're in. They can do their first year potentially, maybe if we up it to a level 6, the academic level, so that it's equivalent, kind of from a college perspective, to be first year of a degree, then we could say, do you know what, we recognise the fact that you've done your year, and now we can give you a place into second year. So that financially, they'll have saved a lot, the cost of going to college, all of that kind of thing. They could have done it locally. So again, I think there's a great opportunity now over the next 2 years or so to look at this, because, as I say, Louise was saying, within Donegal and ATU, they have what's called the 1+4 model, which is a year in FET or the pre-nursing, and you get a direct place, which is brilliant. Like, if I knew I was going to go do my course and get a direct place into first year and go and do my degree, happy days. I didn't get through my CAO, but I'm guaranteed this place. I'll be happy. Wouldn't it even be better if you could go, here you go, do your local college, do it really structured, nice small classes, very supported, and we'll bring you into second year. And then you've only 3 years in college. And sure, look, fourth year is an internship and you'll get paid anyway. So you know what I mean? If you could sell those sort of things to people, because as Sheila was saying, nursing has gone down very much in the rankings. You know, the interest in filling our places isn't there as it was. It was, I think it was 1 to 3.5 for every nursing place we had. There was 3.5 candidates looking to get it. Now it's down to 1.66. So every place there is 1.66 people looking to get it. So that's quite a significant drop over the last 10 years. So that's statistics from the HEA, the Higher Education Authority. So they're really valid, good trends to keep an eye on. So I think we've great opportunities, and I suppose it's by coming and talking to the likes of yourselves today, it's trying to get those ideas. What do you think? Is it a runner? And then we all need to lobby as professionals to kind of go, look, we need to open it up.
Okay. This is like the doll, and now the chance to respond from the department.
No, just quickly, I suppose on a positive note, I suppose the department has been listening, and I suppose we have a vehicle now in terms of the expert review body, and we have a lot of partners in the room that are working with us, and they're about to go on a kind of an engagement, a kind of stakeholder a process in the coming months. And there's a lot of things being looked at in terms of education and access, and I suppose, you know, looking at our graduate to advanced practice policies and making these more accessible in shorter periods of time, looking at our undergraduate curricula, as Carol has been saying. So there's a lot of positive things happening, and I suppose that is a strong vehicle with 47 recommendations approved by the Minister. And I know Rachel is not here today, but she's doing an awful lot of work on the strategic workforce planning, looking at all the options in terms of getting, you know, I suppose bums on seats and people into student nursing places. Thanks. I just felt I had to end with a positivity.
Absolutely.
We are doing a lot.
Absolutely. Okay, so that brings this bit of the sort of discussion to an end, but obviously, you know, there's a lot of interest here, so over coffee or whatever, please feel free to raise more questions with us. This is all about the ideas. So we're moving on now to Roisin. Roisin is newly appointed in her role as education lead for the ONMSD, and HSE people know what the ONMSD is. Whenever I came into the world of nursing in Dublin, first all these acronyms, and I was right, okay, and all I heard was, it used to be Mary Wynne was the head of the ONMSD, and I used to hear, Mary Wynne is all this money. So, and we have all these great staff. So Roisin's newly appointed, so she's going to give us a bit of insights here into the health and wellbeing and the initiatives that are available to the nursing and midwifery profession. Okay?
Thanks. Thank you. Good morning, everyone. I'm really honoured to be here with you today in Waterford, and thank you to Sheila McClelland, the Chief Executive Officer of the Nursing and Midwifery Board of Ireland, and Dr. Louise McBride, President, and all our colleagues, Caroline and colleagues, for inviting the Centres of Nursing and Midwifery Education and myself as the newly appointed Office of the Nursing and Midwifery Services Director as National Education Lead to collaborate with them on this NMBI Series 2023. So this is a great opportunity for the ONMSD and for the centres to be able to share with you education developments and opportunities that we have for registered nurses and midwives and healthcare assistants. I suppose I took up my role as ONMSD Education Lead in July, and this first slide here now, if I get this right. Okay. This first slide just shows you the organisational structure of the Office for Nursing and Midwifery Services Director. And down here at the bottom, we have 11 centres of nursing and midwifery education. We then have 8 nursing and midwifery planning and development units. And Judy is here today, Judy Ryan, and is the NMPDU director here, and members of her team as well. And then we have 4 area directors, and the area director for this area is Carmel Buckley. This, you'll see where
and I've highlighted there under the national leads, and you'll see education there. And I feed directly and then to one of the area directors, which is Dr. Anne Gallen from Dublin Mid-Leinster, and then up to Dr. Geraldine Shaw, who is the director of the ONMSD. So this post is an exciting new development, and one which will ensure that education has a strong voice in the future for nurses and midwives. The ONMSD have a strategic plan, and this is their 2023 to 2025, and this sets out very clear high-level direction for the next 3 years in relation to how we will continue to strategically lead nurses and midwives to deliver quality, safe, person-centred care. So key areas of priority to further build capacity and capability include strengthening education, continuing professional development, clinical leadership and digital competence, which will lead and enable nurses and midwives to contribute to transforming the future of healthcare that can have a real impact on our populations and communities. So the ONMSD national education role is to lead strategically on aspects of nursing and midwifery education, training and continuous professional development on behalf of the ONMSD. And this is going to include the development, commissioning, implementing, monitoring of education and training as required by the ONMSD, and to ensure that there is the development and increased responsiveness of education services in line with the clinical care initiatives. It's also about leading and overseeing and monitoring and managing the Quality and Qualifications Ireland, QQI, its quality assurance agreement with the consortium of centres of nursing and midwifery. So this journey began about 3 or 4 years ago, where the 23 centres nationally, 12 of the HSEs and the National Clinical Leadership Centre for nurses and midwives, and 10 voluntary Section 38 centres came together, and what their purpose, they worked together to achieve accreditation with QQI as a provider of programmes of education from level 5 to level 8 on the National Framework of Qualifications. So my job is sort of like the link between ONMSD and QQI and the services nationally on what programmes you want delivered and what meet your services needs at up to level 8. It'll also promote and encourage collaborative working for the purposes of QQI education and training, and it will also share developments in the implementation and the operation of this consortium model, particularly as it relates to programme accreditation or learners and services needs. Also, to advance this piece of work, we're procuring and implementing an academic learning management system currently, and this was progressed by Dr. Anne Gallen and Catherine White. And this will include leading strategically on blended learning and being able to facilitate the consortium to expand their scope of provision with QQI so that we can deliver blended learning or hybrid or online programmes. Currently, we've just face-to-face accreditation with them. Alongside this work, we have developed a position for Digital Applications Officer and 4 learning technologists. And those were the learning technologist posts were advertised, I think the closing date's the 6th of this month. And they will then support our educators and subject matter experts to develop an extensive and innovative range of local and national programmes. Thirdly, it's about promoting collaborative curriculum development and standard setting for continuous professional development. And this will include modes of delivery, which will include utilising technology and simulation to support programme development and delivery. So you're all aware that Dr. Dara Byrne is now in post as a simulation lead and will be leading out on progressing this forward. It's about supporting the delivery of the Department of Health policy, the ERB recommendations, the NMBI, HSE corporate and national service plans, the ONMSD delivery plan and the strategic plan as assigned by the ONMSD director. And supporting effective networking, collaboration and information sharing between the ONMSD, both internally and externally, which will include our academic, our regulatory and our professional organisations. So this will involve a communication pathway for communication and engagement, which will aim to strengthen the ONMSD's perspective of communication, to be able to centralise communication and to capture education on behalf of the ONMSD. So I will provide a platform for people to channel and streamline communication regarding nursing and midwifery education and training, and support effective communication and information between all the key stakeholders. This is just a snapshot of the key working relationships that, just an initial list, and those who I will have a key working relationship with. So education and continuing professional development. So healthcare is continually evolving with new research and technology and modalities of treatment. So it's crucial for healthcare professionals to keep up to date with the most recent information, abilities and practices, given the ever-changing nature of healthcare. So it's about encouraging nurses and midwives to question practice constantly, expand the evidence base for practice, and to develop reflective practice and critical judgment to improve performance and improve patient outcomes. So nursing education includes embedding a caring professionalism that has patient safety at the top of its priorities, and it respects the dignity and the values of service users and carers. So it requires a constant commitment to quality with a willingness to engage with help. So engaging in CPD, it offers healthcare providers the opportunity for personal and professional growth, whilst also keeping up to date with the most recent developments in nursing and midwifery, providing opportunities for healthcare professionals to acquire new skills, refine existing ones, enhance clinical competence, and broaden their knowledge base. So by staying up to date with the latest research and best practices, healthcare providers can offer evidence-based care tailored to individual patient needs. And consequently, patients benefit from improved healthcare experiences and better health outcomes. So the ONMSD provides a range of options and resources to assist registered nurses, midwives and healthcare assistants to continue with continuing professional development. So this includes our professional development planning framework for nurses and midwives. Your PDP is your continuous development process to support you as nurses and midwives to make the best use of your skills, with advancing your individual plans of your own career, and with advancing the strategic goals of the organisation. Sponsorship schemes are available from the ONMSD, and there is a range of sponsorships available, and some have been alluded to earlier. We have the sponsorship scheme for nurse and midwifery referral for radiological procedures education programme, the nurse and midwifery medicinal prescribing education programme. We have sponsorship of the post-rage psychiatric or mental health nurse education initiative, one for student public health nurses, one for student midwife recruitment, and we have one for the public health service employees to train as a nurse or midwife that Judy alluded to earlier. There is funding for nursing and midwifery educational programmes. So I think in the last decade we have seen, in particular, we've seen huge growth in the number of nurses and midwives that are availing of postgraduate programmes that lead to registration on specialist divisions of the register, like our advanced practice, our nurse midwifery prescribing, nurse referral for radiological procedures, and also in the tutors division of the register. But there's loads of other opportunities to be availed of, like our short programmes. Examples would include conferences, study days and workshops. And then we have our formal academic programmes, which include certificates, higher diplomas, postgrad diplomas and master degrees relevant to clinical practice. CPD, I think by engaging in CPD activities, that will assist healthcare professionals to stay updated and enhance their clinical competence, adapt to regulatory changes, foster professional growth and deliver person-centred care. So as healthcare continues to evolve, investing in CPD is essential for healthcare professionals striving to provide the highest quality of care for their patients. And Ciara and her team will present shortly on CPD opportunities for nurses and midwives that are provided locally here in the Centre of Nursing and Midwifery, and how they support education to implement the national clinical care programmes and to maintain education standards for CPD. There's also local and regional access to both the NMPDU directors and officers, and also to the CNME director and tutorial teams. And there's a wealth of experience within both of those areas to support nurses and midwives in education opportunities. We also have the National Clinical Leadership Centre for Nursing and Midwifery, and this is led by Marie Kilduff, who supports the clinical leadership development for all grades of nurses and midwives nationally. And they deliver leadership development opportunities for nurses and midwives through leadership programmes, development initiatives, webinars and workshops. We also have our national clinical care programmes, Foundation Level 8 education programmes, and they are accredited postgrad programmes which are available and have been developed by the ONMSD and national clinical programmes. And so some of those programmes would include like your emergency nursing and your critical care nursing, anaesthesia. Then we have HSE Land and other e-learning resources for nurses and midwives. So nurses and midwives and healthcare assistants can continue their development through blended and online learning via HSE Land, as well as through other e-learning resources. So HSE Land is the HSE's online learning and development portal and provides really fabulous online resources and learning programmes which have been created to assist nurses and midwives to broaden their knowledge and skill. And then the consortium of the Centres for Nursing and Midwifery, as I alluded to earlier, our primary focus is to work collaboratively for QQI accreditation purposes, which will address the continuing education and professional needs of nurses, midwives and healthcare assistants. So the NMBI, through their scope of nursing and midwifery practice framework, requires that each nurse, registered nurse and registered midwife develop and maintain competence necessary for professional practice. So engaging in CPD is seen as essential in order for the nurse and midwife to acquire the new knowledge and competence to enable them to practice effectively in this ever-changing healthcare environment. So to meet this demand for CPD and expansion and extension of the nursing and midwifery roles, the consortium will seek validation for a broad range of higher education and training special purpose awards for nurses and midwives at level 8 on the National Framework of Qualifications. And new programmes will be based on your identified service needs, organisational objectives and or in response to an emerging service priority within your service area. So currently we've achieved a level 5 for healthcare assistants in medicines management and disability services, and we have achieved our first level 8, which is introduction to low-intensity psychosocial interventions for nurses and midwives, with others in the pipeline. So through engaging in CPD programmes of education and training, nurses and midwives can gain a deeper awareness and understanding of specific areas of nursing and midwifery, ensuring that their practice remains aligned with regulatory, legal and ethical standards. So this will contribute to practitioners making informed decisions and implementing appropriate care plans, staying compliant with latest regulations, minimising legal risks and ultimately enhancing patient safety. So it makes it possible for them to give their service users and patients the most effective and efficient care possible, helping practitioners to deliver that high standard of care to improve and positively impact outcomes for persons accessing services. So finally, just my role is also about raising the profile of the Centres of Nursing and Midwifery nationally, and we have created a web page under the ONMSD, under the Education and Continuous Professional Development tile. And I'd just welcome if you would go in and have a look at that, and you'll see all about the consortium, the programmes we offer, and what programmes are going to be available for you, along with our QA agreement with QQI. The NMBI Series is one way of which we can raise our profiles as centres of nursing, and thank you again to NMBI and to Ciara for taking the lead here in Waterford along with her team. So it's great to be able to come and showcase the great work that has been done locally and being provided by Ciara and her team. And then on the 14th of December, we've also planned an inaugural ONMSD Nursing and Midwifery Education Conference. So anybody who's got an interest in education, you're very welcome to attend, and that is open for registration. And I look forward to seeing as many of you in Athlone on the 14th of December. So thank you very much. I'm going to hand over to Ciara and her team now to go through what she offers here in the CNME to meet your services needs. Thank you.
Thank you all. Well, that's great. Thanks very much. Good morning, colleagues. I'd say everybody's ready for a cup of coffee now. What an awful time to have my presentation right before the coffee break. But look, I'll do my best. I'll try and get through it as quickly as possible so that you all get your caffeine hit. So, you know, I've introduced myself earlier. I'm Ciara, the Director of the Centre for Nursing and Midwifery Education here in the South East, and it's wonderful to have this opportunity to chat with you all today at the NMBI Series, and we're delighted to be hosting the first series, as I said, here in Waterford. So my task for the next 15-20 minutes is to just give a little bit of context with regard to the CNME South East, the work that we do. I'd like to introduce you to the team and to talk a little bit about, I suppose, what guides us and what drives what we do. So, you know, the context for everything that we do and the direction that we take. So we're going to cover these topics, and then at the end, just looking at education opportunities for nurses, midwives and healthcare assistants across the South East. And a little bit then about our education and training figures in the CNME, because I think that's really important. Sometimes there isn't an understanding broadly with regard to the numbers of nurses, midwives and healthcare assistants that are trained, and I suppose the numbers of programmes that are delivered from the regional centres. So just to give you that little bit of information as well to take away. I'd like to start by introducing the CNME South East team. We're a small, compact but high energy and high work ethic team, so we get through a huge amount of work even though the team is small. So I'd like to take the opportunity just to introduce our three administrators at the back. Of course they're at the back, they always hide. So we've Sandra Kennedy, who's our Assistant Staff Officer, and if there's a person in the room that doesn't know Sandra's name, then you've been living under a rock, because Sandra is very heavily involved in obviously all of the contact with learners. We've Louise Beresford, Clerical Officer beside Sandra, and Louise, again, I think everybody here will know Louise's name, does huge work with regard to communication with learners about education programmes and supporting the education team. And last but not least, we have Anne Wall working in the centre as well, and Anne is a Clerical Officer, and again, I would think that most of you will be very, very familiar with Anne as well. So just want to take this opportunity as well to thank the team for all the work that they do. We couldn't do any of the education really without your support, so thanks very much, and special thanks to Sandra for the creativity and the hard work in preparing for today's event. And now I'm going to mortify Karen O'Sullivan, who is our General Nurse Tutor. So Karen, would you mind standing up so that everybody knows what you look like? So this is Karen O'Sullivan. So Karen's been working in the centre longer than I have been working in the centre, and Karen is a huge asset because, you know, when demands come in for education, as I said, we're a small team, and I know I can always turn to Karen and ask for support in planning and developing programmes. She's a huge asset to the department, and I said Karen looks after the general care of the older person, and now paediatric portfolio. We've 2 other tutors, specialist coordinators. We've Rebecca Fitzgerald, who is has the long dark hair. Rebecca is actually at another education event today, so couldn't make it. But Rebecca is our nurse tutor in intellectual disability and mental health. Rebecca joined us 2 years ago and has really paved a fantastic path for intellectual disability and mental health CPD in the region over the last 2 years. She's done huge work. And then our other specialist coordinator, midwife tutor, is Edel Ryan. And Edel is there in the lovely floral dress. And Edel is lucky to be out on maternity leave at the moment, so she's not currently with us. And that's the team. As I said, we're a small team and we get through a huge amount of work despite the fact that there's only a few of us there. A little bit about the organisational structure. I'm not going to go into it in huge detail because Roisin has covered it, but again, I think it's important to give a little bit of context for where we sit in the overall organisation. So there's ourselves, and then we have the Nursing and Midwifery Planning and Development Unit, and I'd like to welcome Judy and the team today, and to thank them as well for their huge support to the centre at all times and in answering all requests that we push up the line. So thanks very much, Judy and team. Then we have the Nursing and Midwifery Planning and Development Area Director, and as Roisin said, that's Carmel Buckley, and Carmel is based in the South-South-West Hospital Group. The Office of the Nursing and Midwifery Services Director then is Ger Shaw, so that is our ultimate line of command and organisational structure. So what guides us? I suppose, we don't pull education programmes out of the air and make them up ourselves and decide, God, that'd be a nice one. I think I'd like to work on that. Everything that we do is driven by strategy. So it's either national strategy or it's regional strategy, but everything that we do in the education that we develop is driven by strategy. And I suppose in particular the ONMSD strategic plan for 23 to 25. So you'll see this coming up in the work that we do all of the time and the direction that we take. But we're also influenced by Sláinte Care, Integrated Care, the Mental Health Commission, NWIP from a midwifery perspective, Shaping the Future for Intellectual Disability Services, the Mental Health Commission. So all of these national clinical programmes, all of these national strategic documents, the expert review body from the Department of Health is huge with its 47 recommendations, and education plays a huge part in that. So we're very involved in groups nationally and regionally to drive the implementation of these strategies and also to represent your voice from an education perspective at that table. Important to say as well, I have it at the end and I sort of debate, does this sit at the end or does it actually sit at the top? And this is our regional training needs analysis. So we send out a training needs analysis every year to everybody in the region and we ask you to complete it. And the reason we do that is what guides us as well. So a lot of the bespoke local education programmes that meet your needs in clinical service are developed as a result of the training needs analysis. So it's so important when you get that email, please don't delete it. Please open it up and fill out the survey. So we've tried to make it as easy as possible in that it comes in an online format. It takes about 10 minutes to fill out. And we ask you to consider a number of different areas. So we use a very, very robust, internationally recognised training needs analysis tool, the Hicks and Hennessy training needs analysis, for the purpose of getting the most information that we can in a short space of time from you. And we use that then to drive and guide the education that we develop. A little bit about our mission, I suppose, and our goals and priorities. And I think, again, this is important to set a context for the work that we do and why we do what we do. So we want to continue to support the provision of high quality care amongst nurses and midwives in our region. We want to continue to collaborate with you, our key stakeholders, because you are our key stakeholders in this region. And it is through engagement and collaboration with yourselves that we can identify education needs, and then we can identify the right people to sit on working groups to develop the programmes that will meet that need. And then together, how best do we deliver this education so that there is equity of access? It's important that we value nurses and midwives and those that support the function of the nurse and the midwife, and that we recognise their impact on patients and families and service users. And that is ultimately what we are all about. All of us in this room, that is our ultimate goal, is to support the service user, the patient, the woman, and that we provide CPD for nurses, midwives and healthcare assistants that empower them and enable them to support these cohorts of service users. Our values are very much based on the HSE values and the NMBI values for nursing and midwifery. And I think we're all really familiar with these. And while we might be exhausted from how hard work is at times, and we're all probably, there's legacy tiredness from COVID, I don't think we ever lose these key tenets of how we act and how we behave. And that's care, compassion, commitment, trust and learning. We like to give that out as a Centre for Nursing and Midwifery Education because we get it back in spades. And when we look for support and help, you, our key stakeholders, are always there to step up and support us. So it's very important, I suppose, as the director of the centre, that these are the values that we live by in the centre. So with respect to care, that we care for our learners, that we care for the nurses, midwives and healthcare assistants that are coming through the Centre for Nursing and Midwifery Education. That can be as simple as a nice cup of coffee when people go out for the coffee break midway through a programme. A nice scone. It sounds very small and very trivial, but they are really important to people, that people feel valued. So that care is there and that we live by that value of caring for our learners and caring for each other as a team. And when people contact the centre, that they are cared for when they request something or they ask a question. That we show compassion to learners and we show compassion to each other and we show compassion to people working in service that are under huge pressure and stress, and that we recognise the challenges that are there and we look to see, well, how can we help? What can we do better to support? Our commitment then, there is a huge commitment in the CNME to providing education that is really high quality, evidence-based, informed. We invite subject matter experts from across the region onto our working groups. We have some of the best people nationally in this region, and we are so lucky to have the expertise and the knowledge. So we're always delighted to show that commitment, I suppose, to our subject matter experts, and they give that back to us when we're looking to develop programmes of education. And trust and learning, I think trust is critically important. If we say we're going to do something, then we really want to do that. There are times when it takes longer to do things than we would have anticipated or hoped, but I think we're no different to any other department in the HSE, that we're really busy, we're short-staffed, and we're doing the very best we can with the resources that we have. But I suppose from our perspective, we will never put out a programme of education that is rushed, that is not well thought through, that is not informed by evidence, and that will not meet needs. So we're not here to tick boxes. We have a commitment to quality and learning, and that trust is there. Our goals, we want to help strengthen capacity and capability within the workforce, and we want to do this by providing, as I said, high quality CPD. But now, thanks to the consortium of Centres in Nursing and Midwifery Education, we have the opportunity to deliver programmes at level 8. Special purpose awards. So that's just a huge leap forward for the Centres of Nursing and Midwifery Education. And I suppose I'm using the word leap, but I think it probably felt at times like moving through very, very deep snow rushing as the lead. It just took, it is such a long process, but it is so worth it. And we want to continue to deliver, support the delivery of service priorities and reforms. So we don't work on our own, we're not in a silo. What's happening nationally impacts the work that we do. So integrated care is probably the biggest show in town, and our education has to reflect that. So how do we support integrated care? What sort of education do we develop in order to support it? And it's really important to us as well that we promote a learner and service-centred approach to education. And that's really important, that everything that we do is learner-centred. And if there is one really important message from QQI right from the start of the process, was that the learner is at the centre of everything. So we can't forget that. Every programme we devise and develop and deliver, whether it's CPD or QQI, we have to make sure that that is accessible to the learner, that it meets the learner's needs, and that when the learner is undertaking the programme, it is an enjoyable learning experience for them as well. So we've 4 key priorities in the centre over the next year or two, and probably into the future as well. And these are very much aligned with the strategic direction of the ONMSD. So it's the quality and safety, education and clinical expertise, service user engagement, and service change and transformation. So quality and safety, the quality, I suppose, and the governance around the education we provide is through accreditation and validation. So currently our programmes are accredited by NMBI, our category 1 and 2, and the level 5 to level 8 will be validated by QQI. And that offers reassurance, I suppose, and it helps with that trust piece that what we're developing and delivering is at the standard that it needs to be at. And that contributes to quality and safety then in clinical practice. So education and clinical expertise, we want to continue to grow and expand as a registered provider of level 5 and level 8 programmes. So we've been delivering level 5 programmes for many years, and now we'll be moving into the level 8 sphere. Service user engagement. So, I've talked about it earlier, working with stakeholders. We can't do anything unless we work together. And I think we've fantastic relationships across the region. And as I said earlier, when I look out across the room, I think I know everybody's name almost. I think I've probably met most people in the room. You're probably sick of listening to me and looking at me, but that's really important, that service user engagement, and that everybody in the room here and across the region knows you just need to pick up the phone and talk to us and we'll work with you. Service change and transformation then. So I suppose this is a really exciting piece, and Roisin spoke about it earlier with regard to the digital lead and the learning technologists posts, 4 of those nationally. So as part of the Consortium for Centres of Nursing and Midwifery Education, we will have access now to resources and expertise to enable us to deliver more online programmes. And I think that's really important, because the message we're getting is people can't travel, people don't drive. We're a regional centre, we're covering 5 counties, it's a huge geographical area. So what do we need to do as a centre to make education more accessible so that there is equity of access regardless of where you're working in the region? And now it's frozen. Oh no. So a bit like Roisin's slide, those that we collaborate with, it's a long slide, I'm not going to go through it all, but any of you looking at it will pick your own specialist area out on this, or your own role. We collaborate right across the board at national level, at regional level and at local level, and that is really, really important to us. This is our prospectus of education and training that we've issued in 2023. So we issue a spring, summer prospectus, and then we review our autumn, winter prospectus, so it comes out again in September. And as I said, the content of the prospectus is based on national clinical programmes, but I think predominantly training needs analysis and the needs identified by yourselves in the clinical areas. But our education and training prospectus is, it's a huge amount of work. It's a really big document, and we have a huge amount of new programmes in this year's document right across all the disciplines of nursing and midwifery. So there is something there for everybody. And if you haven't seen our prospectus, if you Google our prospectus, it will come up. If you go into HSE Land and go into the South or CNME South East catalogue, it is the first listing in our programmes, and you simply click on it and you have access then to all of our programmes. The Consortium of Centres of Nursing and Midwifery Education, huge opportunity there for nurses, midwives and healthcare assistants across the region to attend CPD. Because of the consortium, there will be a national approach to a lot of the level 8 programmes. So if somebody in the room comes to me and says, we'd really like a programme on respiratory care of the patient, what we will do then is put that out to the consortium, see if this is a need nationally. A proposal will be done. That'll be submitted to QQI, and if that's, or to our validation boards, if that's approved, we then set up a curriculum development working group where we've representation nationally on that, and then we work together to develop the programme and submit it for approval. So it's quite a lengthy process, but if there are needs identified, that's the process that we follow to develop the QQI level 8 programmes. And Roisin talked about standardising national education programmes, and that's really, really important. So there's a lot of people doing work out there. There's a lot of national leads, clinical leads. Work has been done almost in isolation. And then at the last minute, I'll get a phone call to say we need a programme delivered in the South East and it's a national programme. So we need to move away from that to a more planned and standardised approach. And that's where Roisin's role will be really, really valuable, in that we're going to be involved in the development of programmes nationally and those standardised programmes right from the get-go. And if it's a need identified in our area, then it will be run out through our centre and made available. With regard to national programmes as well, we use a hub and spoke model. So anybody who's been involved in the Return to Nursing or Midwifery Practice programme with myself will be familiar with the hub and spoke, and that we pick one centre nationally to deliver the theoretical component of the programme. And the beauty of that is programmes can be, we also use it for the National SACT programme with the NCCP. So the programme can be run every single month theoretically by a different centre, and your staff can plug into any of those programmes at any given time. So if you have 5 staff that need to do chemotherapy administration, you can put 2 on January's programme, 2 on February's programme, 1 on March's programme, so you don't have to drain services, but you're still putting your staff through the education. So that hub and spoke model has worked really effectively, and that's certainly a method for delivery that we will continue to use. We also work very closely with the National Clinical Leadership Centre and Marie Kilduff's team. And that's really important that we bring leadership programmes to the South East for staff nurses and staff midwives, for CNM 1s and 2s, for CNM 3s, and those 3 specific categories. So we already delivered the NCLC leadership programme for staff nurses and staff midwives from the CNME. In the spring of 24, we will start to deliver the leadership programme for CNM 1s and CNM 2s. And then towards the end of the year, we'll work with the NCLC to look at delivering the CNM 3 programme. So with regard to the consortium then of Centres of Nursing and Midwifery Education and that level 5 to level 8 programmes, what does that actually mean? I suppose in essence, in everyday practice, what does it mean for you? So the first thing is access. So we're going to have access as a result of membership of the consortium to nursing and midwifery education for nurses, midwives and healthcare assistants at level 5 to level 8, regardless of where the programme is developed. So if the programme is developed up in Donegal, we've got access to it. If it's developed in Dublin, we've got access to it. So it increases access and equity of access for nurses, midwives and healthcare assistants nationally. And for us in the region, that's really, really important. For people, and I think we talked about earlier, with the numbers and the state of the register, when you look at recruitment and retention and what can we do to retain staff, how do we, I suppose, make it an environment that people want to come and work in, what can we do to make it more attractive? So by providing more CPD, more QQI level programmes, we're supporting staff to expand their clinical knowledge and skills. Also their leadership capability, which is really, really important in clinical practice. Also the health and well-being of staff. The more really good staff we have out there working, the easier it is for everybody to be out there working, and the nicer an environment it is to work in, and ultimately impacting recruitment and retention. The digital piece is really important with regard to the consortium, so it opens up access to so much more for a regional centre, and particularly around the new digital role and the learning technologist's role as well. So we can have an idea about how we'd like to deliver respiratory education or cardiovascular education or mental health or ID or midwifery programmes. But if we can find a way to develop those programmes so that they are accessible, regardless of whether somebody drives or not, that's going to be a massive game changer for nurses and midwives and healthcare assistants across this region. So we'll be working really closely with the digital lead and the 4 technologists when they start on how we can increase accessibility of education and maintain the quality of the education. I think COVID taught us you don't have to be in the room in order to be educated, but there is huge variances in quality when it's provided online. So we need to be able to standardise that and use technology to support us. So in essence, I suppose the opportunities that are out there will be around the level 8 programmes, increasing access, using digital technologies to support us to deliver education. Research and innovation, always really, really important. Simulation, everybody's talking about simulation at the moment. It's definitely the big buzz. I feel a little bit hard done by because they have a lovely simulation lab up in Galway, and if I could just pick it up and bring it down here, I'd absolutely love it because it is amazing. But that was the first, I suppose, initiative by the HSE and their first pilot, and certainly our colleagues in the centre in Galway and up in the west would absolutely sing the praises of the simulation lab. But I suppose that's not to say we don't do simulation. There's two types, there's high fidelity and there's low fidelity. We do a huge amount of low fidelity simulation in all of our programmes, and we can't forget the value of that either. But simulation is a coming, and it's a really big part of how we deliver education and support. That interdisciplinary piece as well, which we need to look at, that multidisciplinary approach to education and training. Personal development planning and professional development planning. Well, I'm delighted that Michelle Waldron is here, our NMPDU colleague. So Michelle is the lead in the region, and again, I'd say you all probably have had some conversations with Michelle at this stage about PDP, but that support is out there for you as well. And what we love to do is, you know, when a nurse or a midwife contacts us and said, look, in 5 years' time I want to be here, what do I need to do? Well, okay, pull out your PDP. What are your learning needs? What are your deficits? Have a look at the prospectus. How can we support you? What kind of a path do you want to go on? You're not going to be sent to do higher education until you've built up the base and the groundwork. So do that first. Do your CPD, get those done, put those into your PDP, and then start looking at your further and higher education programmes. So your PDP is very, very important. So Michelle is here today if anybody wants to talk to her about it. I've asked for her permission to say that. Just a little bit about our figures, and I will finish up then, but I think again it's important to go through the figures just to I suppose demonstrate the work that's been done, but also to reassure you that we are doing our very, very best to meet the demands as they arise. So if you look at this graph here, you can see the difference between 2022 and 2023 to date. So there were our total figures for face-to-face and online in 2022. As of June 2023, we had already surpassed what we had done in the entire year of 2022. So we are really driving forward with our education and the numbers of participants we're putting through programmes, which is really positive. And I suppose this is the bread and butter for us. And when we look at these figures as a centre and as a team, it's just great to see the evidence of the work that we're doing. Our delivery methods, and I laugh when I look at this because I think in 2019 and up to March 2020, blended learning or virtual probably would have been 0.000. The rapid transition and that pivot to online education was really foisted upon us, but we took up the challenge and we met it, and we're continuing to grow and expand in that area. So 43% blended learning, so that's a mix of your online or your virtual, whether that's live or pre-recorded, and your face-to-face. And then 45% face-to-face and 12% virtual. So I think that's really impressive that it's almost half and half as a centre. So we're really doing our best to meet that access issue that's out there. This is our growth in 2023. It looks like we took the summer off. We didn't. I wanted to Tipex out that line, but so we didn't. But yeah, so you can see the growth. I mean, the difference month on month in the numbers that we're pushing through and the education that we're providing is really, really satisfying. Again, you can see the growth there in face-to-face, 1834 and 22, and by June 2023, we were already surpassing those numbers. So we've delivered 147 training days so far this year. Hard to believe when I look at these figures. And that's right across the disciplines of nursing and midwifery. So obviously our range of programmes for general and acutes always tends to be bigger because the demands are greater. But with Adele in the midwifery role, we've seen a huge uplift in midwifery programmes and attendance at midwifery education and engagement across midwifery services in the region, which is so welcome, and we're so pleased with that. And then with Rebecca and ID mental health as well, that has really pushed mental health and intellectual disability education onto the agenda and driven programmes of education in those areas as well. So you can see there's a huge number there, and it's just, I suppose, demonstrated there month on month. So we have 108 training days for the last 4 months of the year planned, and you can see the bulk of those are in October. The reason they're in October is that seems to be when suits services best. So September's a busy time, people are going back to school, there's still annual leave. October's a really good month, so we try to fill October and really front load October with programmes. Then November it starts to taper off, and then into December we'll continue to deliver programmes up until the second week of December. So this will grow. These are our programmes planned at the moment, but as requests come in, the number of training days to be provided will increase with that. But we tend to taper off around the end of the second week in December, simply because that's when people are taking holidays and attendance starts to decrease. And this is just, I suppose, some feedback that we've gotten from participants, and we always welcome the feedback. But I suppose the key words there are knowledge, information, safety, excellence. That's what we strive to achieve in every education programme that we develop and deliver. So they're the words we want to see in a word cloud coming back to us at the end of our education sessions. And just to conclude, I thought these words really summed up what we're about. We are here to provide a service for you, our stakeholders. That's our job. That's what we're here to do. I think everyone on the team loves the job that we do. There's days like yourselves in clinical practice where you could absolutely walk out the door and say, I'm never coming back. But in general, and I suppose in the main, it's a brilliant opportunity to be able to support nurses and midwives, to be able to provide a service and to serve our colleagues in clinical practice that are tired and that do need support and do need compassion and care. And we're really, I suppose, focused on, at the end of the day, quality care, competent care, and nurses, midwives and healthcare assistants that can go out and provide a quality service, helping service users, patients and women across both the community, the acute and all of the disciplines of nursing and midwifery. So that's it from me. Thank you very much for your attention.
Okay, Ciara, that was brilliant. Just sitting thinking, really, really great stats, Ciara. It's so interesting, isn't it? Because all of you, I'm sure, are intersecting with the CNME to acquire further education, training and support. But you're doing it as an individual. But when you see the global picture about how much you're actually doing, it's really fantastic to show the quantum. I suppose just to make the connections here. So some of the stuff that was coming up on the slides totally resonates with us. So the PDPs that I know have been rolled out, ONMSD, CNMEs have been really supportive of that. So we have a bit of our legislation has never been commenced, and that's about the maintenance of competence scheme. It's a big rigmarole of a title, but it's called. We have a responsibility to monitor the maintenance of competence. So you, as registrants, will know that under this code, you have a requirement to do that anyway. But we have apparently been given these powers in the legislation, but we haven't yet commenced them. So we're really working on this, and we're trying to think about the most proportionate way to record that registrants are doing whatever they think they need to do in their environment. It's a real struggle for us to make sure that we're being proportionate, which is a new big ticket item now at a European Commission level. They're talking about proportionate intervention when it comes to regulating and frameworks of safety. So we're trying to be proportionate in what we're saying. So the PDP is a game changer for us, because you're doing that as HSE staff. The PDP is becoming sort of a mandatory feature. So to some extent, it's focusing the mind on what you need to do in your environment and how you need to maintain your competence. So we will be using that as one of the big, if you like, points of connectivity when we bring our proposals forward, and that's really imminent, that work. Although we've started it and stopped it a number of times, we are starting it again, and there's the first meeting on the 14th of September, so we will be coming out and publicly consulting on that. But we're trying to make, if there is a tool there that's recording what's going on, and if we have our colleagues who have huge amounts of resources and are deploying those to meet the needs of the service and the employee, then we're assured that it's being taken care of. So in the big employer, i.e. the HSE, we think that's going to be, we have great evidence of this being progressed and we're all on the same page. Obviously, if you're involved in a more specific and remote employment setting, we'd have to be more concerned that you are getting, because there's a requirement in the legislation that an employer must provide for a registrant to have her or his competence maintained. So we obviously there's a responsibility on the employer, but will be more focused on those people and less focused on the HSE, because there's such great structures in place, and we're hearing about that here. One of the other things that we have a responsibility for in the NMBI is that we, at the minute, and this is a bone of contention with the board, we approve every substantial course and every small course. That is, now not every course, because we were talking about that earlier, but every course that's put our way we have to look at. There is no requirement really in the legislation for us to do that. So if I'm thinking about how I save money, it might be one of the things that we would be testing about dropping or doing differently. But it does help maintain the standards of those courses, and there is a sort of a pride that goes with it, and we've consulted on this and heard this back to us. So you can see here that, Carolyn and her team do site inspections, and the site inspections are to the likes of Louise's organisation, who run an undergraduate course. So whenever we were looking at this, we thought again, how do we be smart? So we have changed our approach. So we now go out and look at the undergraduate courses that are being run, and we sort of are more, there's much more resource goes in, so we fly in, swoop in, and we actually do horrendous things like talk to the students in the corridor, sort of hijack them and find out how they're really having, what the experience they're really having. But also we look at the postgraduate, the big postgraduate courses that are being run in the university settings, and mostly those lead to registration and new division or some form of specific job that people can acquire only because they've got that qualification. But it means that the HEI doesn't have to constantly be sending in returns to us to say this is the same courses we got accredited 5 years ago, re-accredited. The same with the CNMEs and the consortium. So they have to submit their courses as well, and we can see the quality. But it's all about us from a bird's eye view, knowing that the quality of education is at a certain standard that keeps our nurses and midwives optimally, right up there at the top of the European standards. So that's where we intersect really with the CNMEs in relation to that quality, and also with the quality of the sort of the smaller courses. So have you any questions now for the ladies? None for me. Yes, TJ.
Apologies, I'm back again.
That's all right.
I just want to reassure you, Sheila, Louise, Roisin, and also up to the CNO's office via Georgina, that the work that Judy and Ciara and Rika Duff that they do with us is superb.
Great.
It's the highest calibre. I've worked with them closely now for a number of years, and I can only speak very highly of them. We maximised that, and we were very, very lucky to have our regional NPDUs and our CNMEs, and we work very closely then for the nurse leadership as well. So we would advocate that the funding needs to continue and in fact increase, because we see that our depth of experience and knowledge within the nursing profession tends to, within the acute setting anyway, drops off after 50, 55 years of age. Unfortunately, the activity is so high that we tend to lose it. So the need for education is there. So I just want to send that back to the NMBI board, as we really appreciate what the work that the RCNME and the NMPDU do locally here. I would also just like to say about the when we're talking about education and criteria as well, that the CNS and the ANP job specs, we just need to be cautious in regarding to looking into criteria and not dropping that too much. And I would just I've worked with Carmen Buckley recently on the CBC job spec nationally, and to review that, and it was a big debate that we had. There was a conglomerate really of us who partook in that. I would just ask the board to be conscious of that if we are looking at because I do know we don't have that depth of experience, and there's a huge need to get this launch care rolled out, but that does have repercussions if we do significantly drop the criteria. Also, I just would to continue on the great work that of education that the RCNME and the NPD they all assist us with. I cannot undersell the importance of clinical skills facilitators within the clinical environment. They support what the RCNME do and NPDU do. They are the constant on the ground And I can just say, when I took over my post, I had no CSF, and now I have a team, and I just can't underestimate, or I can't oversell the importance of those. So I would just like that to be a key point brought back as well. Thank you.
Okay, can I just come back on that? And it's really interesting for us to take a note of that, because sometimes things at work, it's silence, and then all of a sudden somebody decides that there's not much chat about it, so they take the funding away, and it actually wrecks something that really was working well. So it's really important to endorse what works well and make sure that we respect and regard that. Roisin.
I just want to say this to echo your point, your final point there. We couldn't function without the subject matter experts, without the clinical expertise, without the wealth of knowledge, that the nurses and midwives bring to our programmes. We work so well with them. I was previously a director of Centre in Donegal, and we couldn't do it without them. They are the linchpins really, because they're bringing that expertise. And a huge thank you to the directors of services who recognise the importance of that evidence-based, the work that they're doing that's so up to date, to come and impart that knowledge to other colleagues. And we couldn't do that without working with services, clinical facilitators, advanced nurse practitioners, clinical nurse specialists, staff nurses, staff midwives, all the roles that are out there. I mean, there it is. And we work so well together. There's real collaboration.
And you're our key people, and as Roisin said, we can't do the work that we do without your key people as well, without your expertise, and your contribution to programmes. And I think that's the USP, or the unique selling point with regard to Centres of Nursing and Midwifery Education, because we have that direct access, we have those relationships with clinical services and with subject matter experts and with the directors of nursing and midwifery right across this region, who without fail release staff to support working groups and the development of programmes. And I suppose as the director of the centre, I'm hugely grateful to you all for that, because we just couldn't provide the quality that we do if we didn't have access to your resources as well as our own. So thank you very, very much for that.
Okay, let's go here.
Marie Lasta, Nurse Practice Development Coordinator at Tipperary University Hospital. And it's in relation to education. I was reflecting as I was submitting my PDP to TJ last night. I kind of got shocked when I realised I'm 15 years in the role, and the role has changed dramatically in the last 15 years, and what has significantly changed in the last few years is education and training. I was on my own for the first, up to about 12 years ago, I was on my own. Up to the first 12 years I was on my own, and the education and training on the ground is what I'm talking about now, is on site in the hospitals has exploded. The need for it, some of it has been driven by trying to support the new overseas nurses coming in. We also get a lot of nurses who have worked outside of the acute service for a number of years and are coming back into the acute service. They need the support. And then we also have the need to continually upskill, because of the acute service is very dynamic and fast changing. The complexity of, say, medications and the needs to constantly engage with medication safety and the deteriorating patient. We started off with the Compass programme in 2012, but we're on probably, I'd say locally, version 7 of our own version of the deteriorating patient now. And this has all been driven. As you can see, we have fantastic support from the CNME, but what we're finding now is that we're doing so much education and training within nurse practice development in our hospital, and a lot of the other hospitals could probably give the same report, that it is impacting on other practice development work very, very significantly, Without the clinical skills facilitators, which we've really only had in the last 2 years, we'd be at nothing, and they're managing and supporting, and the clinical skills have set up. Simulation, as Ciara said, is the buzzword, and we have simulation programs now for critical care, management of critical care patients. But then that depletes their availability to be on board with the nurses who need them. So we're torn between, and it's all resources, it comes back to resources. But it's a big area that's growing, and it's an area that we need to resource significantly. The CNME have been a huge support to us, but they have a huge remit in this region, huge remit. And they can't be everywhere, and they listed their team, they're a small team, but it is definitely something that's going to have to be resourced everywhere.
Okay, thank you. Thank you very much. Point really well made. Is this lady here?
Hi, I'm Irene Reinders, Practice Development Coordinator for Cork, Kenny and South Tipperary. I suppose, again, probably on behalf of all my colleagues in Waterford as well, that there's been so much great input into mental health services from both the NMBI and the CNME. I've been around the practice development a long time. Helping Louise go back a long way. And I suppose when I started off first, there was very little input into the mental health service and not a huge amount of communication both ways, and it's just completely changed nowadays. Rebecca has been a massive support to us and has produced some fantastic programs, and it's been I'm working with our colleagues in the NMBI as well, but it has changed hugely. We don't have practice facilitators, I think there was one. But and our team, yes, our team has increased from not having even nurse practice coordinators in the region. But huge thank you to both the NMBI and the CNME for supporting mental health and developing it over the last couple of years.
Brilliant, brilliant. Ladies, do you want to respond? Just say delight.
Oh, it's great. No,
post it to social media.
Yeah, no, it's really, it's lovely. You see, I suppose it's lovely to get that feedback, because sometimes you don't realise, we can assume that we're making an impact when we look at figures and when we look at attendance at programmes. But it is lovely to get that feedback. And I know, listening to Marie's point there as well, there's a huge amount of work to be done, and particularly out on site, and with the likes of simulation, with the likes of very, very skills-driven education, where it is getting nurses to the point and midwives to the point where they can operate independently on the floor, particularly colleagues that are coming in from overseas and adoptees. So we know that, we appreciate the really positive comments and the fact that, it's lovely to hear we're doing a good job. I think for the whole team, that's just really, really positive and will drive us forward. But we're also very conscious that there's a huge amount of work to be done, and I look at community services, integrated care, whether it's from a midwifery perspective, intellectual disability, mental health, acute, that's where we're going. It's integrated care, and how do we as a centre support that? And at the moment, I would say there are deficits there, and we need to continue to grow and build in that area, and that's certainly an area that we will be prioritising going forward. But yeah, work to be done. I'm like who said it's not done, 30 hard, not done, not more to do.
Okay, Ciara, thank you. Okay.
Thank you. My name is Aminat. I'm an agency nurse, but before that I was working in a private nursing home. So my question is, the services of the CNME, can the nurses working as agency nurses and those in the private nursing homes avail of these services? Because throughout my stay in the nursing home, I actually didn't know about this.
Yeah, it's a really important question, and I suppose it's a question that comes up all the time, and it differs nationally because we're funded by the ONMSD. The ONMSD is a HSE organisation and is funded by the HSE, and so all of our funding comes from the HSE, and ideally should be spent on nurses, midwives and healthcare assistants working in the HSE. And I think the level of support provided to practice nurses, nurses working in private nursing homes, agency nurses differs nationally. But certainly as a centre, we do provide education to nurses working in nursing homes, in practice care settings. Not so much agency, because it is the responsibility of the agency to provide CPD for their staff, but certainly with practice nurses and those working in private nursing homes, we would do our best to support. They would be notified of education programs that are relevant to their area of speciality. And then if there's other programs, that, you know, are nice to haves, are nice to attend. If there's spaces available on those and there's empty seats in the room and there's a cost associated with delivering the programme, we would absolutely welcome staff from nursing homes and practice nurses into those education programmes as well. Yeah. Does that answer your question?
Yes, thank you.
Okay. Miss Georgina?
Yeah, just to add there what Ciara was saying, I suppose under the expert review body, again, we are, one of the recommendations about reviewing the funding structure to make sure that we're, I suppose, meeting strong care standards of that integrated care, and of course that's primary care, nursing home care, all of that. So there is a lot of work being done in that area at the moment. And I know that there's work done on the strong care innovation funding as well, around postgraduate courses for community and practice nurses as well. So we are kind of moving more into that zone. We need to. So again,
like if there's resources and there's education staff, tutorial staff, and people qualified to develop and deliver education, and there's subject matter experts in the region that can support the delivery of that education, it just seems a shame that anybody would be excluded from that. So, review of the funding structures probably is critically important if we are to meet the recommendations of the ERB as well, and particularly around education. But certainly as a centre, we have never been shy about supporting colleagues in I suppose, more non-HSE areas of work as well. A nurse and a midwife is a nurse and a midwife regardless of where they're working, which is sort of has been our ethos for a long time.
Okay, this gentleman here.
I'm going to start off here a little bit. Tom Collins, my name, from a private nursing home. I would be of the opinion that we struggle to get training courses for our staff in the nursing home. We spend a lot of money recruiting nursing staff, which are then taken over by the HSE, and then the recruitment starts, or the training starts. Would it not be in everybody's best interest to provide training for staff in nursing homes? And also the numbers of healthcare assistants that are working in nursing homes is far greater than the number of healthcare assistants working for the HSE. And there are excellent healthcare assistants within nursing homes that could be trained as nurses. I think the blinkers need to be taken off. I've been saying this for years and nobody has listened.
I wish I could give you an answer, but I suppose I don't deploy the budget for the own MSD, but certainly there's huge merit in the points that you're raising, most definitely. And there are moves in the HSE, to be fair, as well, with regard to more inclusive education. As a centre, we recently ran the National Induction Programme, education programme for nurses coming into non-acute care areas, and that included nursing homes. So we would have had, and care the older person facilities across the southeast, so we would have had, can't think of the numbers, maybe 17, 18 people on that programme from across the southeast that were going directly into care the older person services and not into the acute service.
They're probably going to a HSE.
I would say the majority, actually, they probably were, because they were recruited by HSE. Yeah.
But there is I tried to log on to that course for some of my staff, and it won't allow us as a private nursing home on HSE land. Yeah, we don't get a lot of them on HSE land. We might get education management.
You can't access programs on
No, you're very restricted.
You're very restricted, yeah.
On HSE land?
As private nursing homes.
Private nursing. Yeah.
But I do know from a national perspective that where there are spaces available, that we would definitely welcome private nursing home on those courses. And we've offered them in Donegal to private nursing homes where we have spaces.
Oh yeah, we do get on, but we don't always get the spaces.
No, some are very, very popular, but then there's a demand from another one, and we always offer it out.
Yeah.
And I'm sure that would be.
Yeah, but I suppose I'm looking at it.
A structured pathway.
Yeah. And I think it's really important to raise it. This is the forum at which to raise it. That's what this day is about, so to raise concerns.
Yeah, because I feel it's the HSE to run everybody else. Like private nursing homes, we're all nurses as well, so we deserve to get the same training or opportunities.
And it just, again, it comes down to funding, isn't it?
I know it's the work that is being done with the expert review by Nursing and Midwifery, as Georgina has alluded to, that there is work ongoing on that, and there may be recommendations from that.
Yeah, there's definitely, look at the funding education. Sorry, I don't know what's happening.
No, I don't know either.
For, I suppose, looking at primary care, community care, which is involving all sectors, including private sector as well. So there's definitely a move. There's in terms of GP services as well. There's a strategic review of GP services, and we have nursing sitting on that strategic review panel as well. I suppose looking at supports for those. So there is a move looking at how we integrate all the services. And I suppose there was also recommendations, I think, coming out of the expert panel report on nursing homes as well in relation to access for education as well. So there's been some, I suppose, talk around some of the estimates around some of that as well. So I think there is, people are hearing, and I think there will be more happening in that field. Maybe not quick enough, but it is moving in the right direction, I think. And I suppose then there's, I suppose, the balance in terms of private sector funding and public sector funding and where the line is, where the line meets. And I suppose I think we kind of have to have those kind of conversations, and they will be commencing in lots of forums that are established now between the department and other agencies. So I think that's a good thing.
Okay, thank you. We can continue that maybe offside. Okay, I think this is the final question. I'm getting the glare here from Dee again, so I'm getting scared.
Everybody needs their copy.
Yeah.
So I must thank everyone again, having availed of some of the trainings. They're just top notch, and they've helped me a lot as an individual in my practice. So I just wanted to make a recommendation, being a person who studied overseas and came into this country to practice. I think there is an aspect that I would like to see more, especially for international tertiary trained nurses and midwives. A acculturation program, something to help us, get into the culture of Ireland. And for some of us, we are coming from where there is monoculturalism. Like before my practice in Ireland, I would have looked after like 99% of people from my country. So, but coming into Ireland, I'm looking after like so many country people in a shift. So being able to understand that difference, and as well as maintain my individuality. That's just what I would say.
That's so important, and certainly the National Induction Programme that I spoke about there a minute ago, that was a huge part of that programme, was that cultural integration. Even right down to colloquialisms and language and the way that we speak. And when you're on a ward on a Sunday in Wexford General Hospital, all the talk is about the hurling that day, but what's hurling? It's a very Irish thing. So that was a huge part of that programme, was that cultural integration piece. And the feedback that we got from participants was just wonderful, because we even looked at, care of the dying person. It was a programme that was developed nationally, care of the dying person, care of the deceased. So what are the cultural differences there? What do we need to do? And what do you bring to us as well? So what do our overseas nurses bring that we could actually include, that make how we work better and more positive? So that cultural integration is absolutely huge, and yes, it does need to be addressed. And I think for the acutes, it's definitely a piece of work that needs to be done on a national level as well.
Okay, Karen, do you want to respond? And then I think we'll close.
Thanks for bringing up a piece about culture bit. We're doing a bit of work by the end of this year. We'll have it done of just reframing the code of conduct and ethics with the scope of practice, because we know there are two stalwart documents for nursing and midwifery professions, but often they're used independently. And I know I would be really good on the scope, and when I went to work in NMBI, one of my colleagues, Lorraine, who all she ever talks about is the code of conduct and how important that is. And in fairness, we'll hear from Joanna later that really from a regulation point of view, from a nursing professionalism, the code is actually your most important, and the scope is part of it. So we're going to try and fix the kind of how that's delivered to you as professionals, so it's more understandable and they speak to each other better. But as part of that, we're aware that, as you say, that delivery method of just having a document on a website to be downloaded and picked apart is kind of old-fashioned. So we're going to try and go into that 21st century place of e-learning and having something from a video perspective and some sort of an e-learning program on the code of conduct and ethics with the scope in it. And that cultural piece has to be really, really important. We're going to have maybe like another type of module, especially for our overseas colleagues and our internationally educated nurses as well, for, you know, so that they can do it online before they come, and it kind of gives a national standard of, you know, from an Irish perspective, when you come to work in healthcare, whether it be acute or community or wherever you are, that these are the general principles that you need to look out for. So they can be kind of prepping in their heads and minds before they come, so that when they come to Ireland and land, it's not all, wow, tsunami, what are they talking about, where did this all come from? So I think you can do some prep work usually in advance online. It just kind of gets people into the right frame of mind. So fingers crossed. We'll be coming out to consultation on the code, the new version of how it is, same types of principles. We're not changing the standards as the fitness practice department will kill us if we did. But basically how it looks and feels and the language and how it talks to then our education practice and standards. Hopefully it can make a bit more sense to kind of the everyday people like myself. So we'll have that out for consultation at the end of this year, and then I say that e-learning piece hopefully will be pending towards the end of this year, so we'll have something else next year.
Potential as well, because I just completed my master's there last year, and that was my topic of my dissertation. And my colleagues and some of the online studies I did was just, most times it was just the culture. The money was good, then the culture and the whole, you know, getting to the country and being able to be part of the country was a big deal.
Very interesting.
A major stakeholder here already.
Totally. Need to see your master's dissertation. Okay, everybody, can we, I know there's some people, so if there's questions that people want to ask over coffee, absolutely, and maybe we can do them up at the very end, but I am being told that people are beginning to dip and need their coffee. So why don't we just do that and come back then for the next session in 20 minutes or so. Okay. Is everybody ready for the next session? Weren't okay. I know these events are all about the networking, so it's a bit harsh to draw it to make people bring them back to order, but we do need to continue because there's loads more to cover. So I'm now going to move on to my colleague Carolyn. You've seen her popping up a couple of times already. So she is going to start this session with looking at health and wellbeing. We did listen last year when we were on the road on some of these. The issues that are coming up are what people said they wanted to hear about. So we're trying to make sure we pack everything in that was mentioned in relation to what people felt would have been beneficial last year. So this is one of the areas that there was significant feedback on. So I hope you enjoy the next sessions here. Okay, Karen.
At least I get yous after coffee, so you're all fine and well adjusted and in good form, so that's a good thing. So thanks, Sheila, for the introduction. My name's Carolyn Donoghue, and I'm the Director of Education Policy and Standards for the last 2 years with the Nursing and Midwifery Board of Ireland. And I must say, it's probably the best job I've ever done. So just shout out to the NMBI. It is a great place to work. And it's a privilege for us to be able to direct the professions of nursing and midwifery into the future with all of you, our colleagues and our stakeholders. So as we said last year, we did get a session, we did this roadshow last year, and one of the overriding things and themes, and I know we were coming out of COVID, was that, you know, health and wellbeing for staff, for the nurses and the midwives at all levels across practice, really was an issue, and people were very stressed and burnt out, and, you know, it became something that people really wanted to discuss and talk about. So we decided that going in a year later, it'd be really interesting to do a check-in and just see where everybody is now at this stage.
So just to kind of give us a bit of context, and I'll be sharing this session with my colleague Kate here, who will be talking about it from a regional perspective. But when we talk about well-being, if we look at the World Health Organization, they would say that it's a state of complete physical, mental and social well-being, not merely the absence of disease. And I think I really like that because it puts that positive spin. Nursing and midwifery can often talk about the bad things that go wrong. We're always looking for the deteriorating patient or things that what's going to go wrong, what's the risk, what's the problem. Whereas actually we need to start to, certainly from our own perspective, think about what's our well-being. You know, what are the positive things that we can bring to ourselves and all other areas. So it's interesting, when I looked into this area, you have to go back to the ancient Greek philosophers to figure out, actually, we didn't invent well-being. It was around about 450 BC, where one of the ancient Greek philosophers, Aristoppus, he started it all off. So Aristoppus said that actually well-being was really important, and it was about finding pleasure and avoiding pain. Now, this is hedonism or hedonism. So I don't think I think we've evolved a little bit from there. So then about 100 odd years later, then we had Aristotle, the one we all know about. And he was very much, I think he resonates a lot with our profession, because he talked about the origins are in virtuous and purposeful living, psychological well-being, and having a positive pursuit of goals and a higher purpose. So that really sits with us here in this audience, because we're all about positivity, driving force and doing better, and that altruistic nature of our professions. And then in more modern times, in the last 100 or so years, they've really brought in that social element. And they've decided actually that, yes, the pursuit of goals and the physicality is really important and the mental part is very important, but actually socially, well-being is just as important, and it's that connectivity is really important for us as how we as individuals connect and have our systems and structures within our ecosystem. So again, that social well-being is just as important as the physical and the psychological. So within our profession, we know, as the INMO have done a really good survey on health and well-being of staff coming out of COVID, really that there's a crisis in healthcare, and we all absolutely acknowledge that. It's a tough place to be working for all staff. And we know that 94% of staff say that their health and well-being is negatively impacting their psychological well-being from a work perspective. So their job is affecting them psychologically, 94%. So that's pretty much the entire profession. So we have a really, really serious problem. And that 89% of them say that at least they're somewhat burnt out because of work. So these are the facts, and this is the reality. So we need to think about, well, where do we go from here? So we know it's a tough profession. We know resources are scarce. So what are we going to do? How are we going to try and address it? So my approach to most things, if I need to know what it is first before I can try and fix it, because we're great at fixing. That's one of our traits as a professional. We like to fix things, but we need to understand, what does it mean first? So again, there's a really nice piece of work that was done in 2022 by Patricia et al., a bunch of kind of collaborative colleges across the US, and they looked at defining nurse well-being at work. So this is pretty good. So they've said it's a nurse's positive evaluation of oneself and one's contribution to the work of nursing, allowing for the nurse to be the best possible at a given point in time, with the ability to adapt to and overcome adversity to the extent possible. So there's a little bit theoretical, but overall, I quite like this. This resonates with me. So it's about how nurses positively evaluate themselves and their contribution to the work that we do, the work of nursing and midwifery, allowing for us to be at our best at a point in time where we can adapt. And that's where you see all of those other pieces that kind of add in here, where we can adapt and overcome adversity. So that's really, really important. The most extent that we can within the resources that we have. And this, to me, is the crux of it. Nurses' well-being requires that basic and higher level needs are met at both the individual and organisational and community levels. So quite often you'll see there's a lot of kind of conversations about what you can do for yourself, and nurses taking on the responsibility. And there's some surveys out recently that would say when nurses were asked, and midwives, about health and well-being and what did they want, they said, don't give me any more resilience courses, I've had enough. Because they felt that they were being told, you need to do a resilience course because obviously you personally are not able. You know what I mean? Whereas actually, no, it's trying to give you tools. So I think it's back on us now as a profession to kind of decide, how do we direct this? How can we solve these issues? Both at an individual, but also there's a half of that other picture is your organisation and the community of nursing and our profession of nursing. So it's not just the individual, there's a bigger system there. So the individual attributes that will lead to well-being: happiness, satisfaction, optimism, compassion, gratitude, forgiveness, and sound body and spirit. But I think the organisational community attributes are the ones that I love to look at, and I think this is something we as leaders could work on. Teamwork, sense of mission, pride in your work, and social integration. So again, these are things to think about when we're trying to solve this problem. And what's the point? Is there a consequence or a purpose to all of this? Yes, there is. Because if you can solve the well-being problem of the individual within an organisation and their community, you can get better resilience, better collegial relationships, continued growth and development, empowerment, purposeful work, and physical and mental health. So the rewards can be great if we can figure out, both at an individual, an organisational, and a social perspective, how to crack this nut. So one other piece that I would draw your attention to, and I would encourage you to have a look at. So this is a report on the future of nursing 2020 to 2030, charting a path to achieving health equity. So we know from all the recent research, nursing really is going into that space of equity and health equality and trying to push the balance for the people that we look after as to how they access and understand healthcare. And we're really powerful in that space, in that whole health promotional perspective. So this really, really good report now, it's 460 odd pages, and I would say go straight to chapter 10 because that's where it talks about the health and well-being piece. But they have some really nice talk about it and research, and they've synopsized a lot of the pieces in relation to health and well-being. And for them, they say, for nurses to address the many social determinants that influence health, from housing to violence to poor air quality, they must first feel healthy, well, and supported themselves. So for us to fix everybody else, we need to be well ourselves. And I know we all know that, but I think it's important to reinforce that. So for policymakers, employers of nurses, nursing schools, nurse leaders, professional associations, and nurses themselves, we all have a role to ensure that well-being of the nursing workforce is to the fore. So how do we improve the health of nurses? We look at a variety of targets. Physical. Always start with the physical because we're nurses, although my mental health colleagues will say no to that. But basically, your activity, your diet, and your sleep. We're very good at telling our patients and our service users the best way to behave and all the rest, but as we go to the canteen and eat a plate of chips. So again, we just need to take some of our own advice sometimes. Substance use. And again, from a fitness to practice point of view, we might tip on that later. This is just a crutch that sometimes we as professionals have greater access to. We don't have any substance abuse greater than the general population, but we have better access. So we are at risk. Resilience, as we know, mental health, ethical competence. So again, that moral injury and the point that sometimes we have to go to work and things go against our values, but we still have to go and meet the needs of the patients in the resources that we have. Incivility, bullying and workplace violence. 20 years ago, if we were given this presentation, we wouldn't be talking about that. But I actually like the fact that now it's becoming obvious and it's been written about and it's been recognised. That's a huge part of health and well-being. It's us looking after each other, but sometimes we're not nice to each other as well. So we need to remember incivility, bullying and workplace violence have a huge part. And then racism, prejudice and discrimination. And again, we have a really diverse nursing and midwifery workforce now. Our patients and our service users are also equally as diverse. So we've got to really make sure and go to work every day to make sure everybody is treated the same with civility. So they're the main elements. So now I would just like to ask maybe one or two people around the room, what is your current health and well-being status within your services or within yourself? Is it working? Are people feeling better in work now? Are they still as stressed as they always were? And is there anything that's out there that you're currently doing that maybe is a good thing that you'd like to share with the group? Just for 5 minutes. So if anybody would like to offer. Great.
I suppose the challenges with setting up of the workplace, I suppose, wellness committees in various areas, and I'm just thinking of a 40-bedded unit. And the challenge is that you're linking the staff then around redeployment, around increased workload. So I suppose it's the balance of trying to support the wellness of the staff while also trying to manage and meet the needs of the service. So, that's a real challenge, I suppose, trying to get overarching piece as a manager, as a leader within the service. So that's, I suppose, just an observation that I've had and something that I'm very aware of, I suppose, with the staff that I work with.
And I think you've hit on something really important. We often talk about the health and wellness of staff, but you as a manager, I know from being in management positions, you take it all personally and you take it on board and you take it home. The fact that you've had to redeploy somebody maybe to an area they're not happy with just to keep the service safe, but you're also human at the end of the day. So you as managers, you have to be really careful to watch your own wellness as well, because it can take its toll.
Yeah, and that's not really the point I was trying to make. I suppose the point is for the staff on the floor that they feel almost that this is kind of a contradiction, that we're nearly ticking a box in terms of wellness. So it's not to tick a box, but we're trying to tick all the boxes. So that's, I suppose, and they recognise that as well. It's just a challenge, it's an observation. And I still think we need the wellness committees, we still need all the interventions, the civility in the workplace, no bullying, all of those things. But it's just, I suppose, and we spoke about training earlier, and I suppose the elephant in the room, alongside all the positivity, is that many services are working with probably in our scenario where we're working with probably 30% shortage in our workforce. So it's really challenging to meet the training needs and the development needs of staff. But we're still doing that, but I suppose it's just not as frequent or as available as we would like it to be.
And where do you think your wellness kind of comes in that totem pole? Are you able to, I know you said you're ticking boxes and stuff to make it available and stuff, but are the staff able to avail of the stuff, of the opportunities, do you think?
They are, and I think, look, we have to get it off the ground, so it's kind of leadership-led in terms of senior management. The idea is to pull back from that and let the people on the ground, I suppose, bring the wellness up so that there's kind of a delineation there. So I think we're working on that. We're about 4 months in. So, yeah, I suppose, look, it's just about, we're very conscious of it, and I think staff are talking about awareness, are talking about stress, and I know we have our stress risk assessments and all of these things, but, it's about being meaningful, I suppose, acknowledging that it is stressful, that staff are becoming, overworked, etc. So I suppose just the complexity, I suppose, of the whole
Absolutely, yeah. Hugely complex.
Sorry, I work in the area of midwifery here in Waterford, and I echo what you're saying. The wellness programs have to mean something, and I do. There has been huge strides made in Waterford with that, and ability to eat outdoors and have facilities to do all of that, and have your food trucks and all of that. But as managers, it's incumbent on us to make sure the staff are released to do that. They're released to go to any training that's offered. Now, we're particularly lucky in the midwifery side of things in the South West Hospital Group, is that we have access to a part-time clinical psychologist.
Good.
And, you know, I'll be the first to say I thought a half-time clinical psychologist for 4 maternity units. I thought, no, look, it has been hugely valuable.
Okay.
And it has been, she's particularly good. She comes to the service, and Janet here is the AGON, she coordinates it. You have time slots for people that might want to come in from home to talk to her.
Yeah.
I need to be clear, it isn't a moan fest. You don't come in to tell her that they're short-staffed and you don't like this and that.
Yeah.
There are some very real constructive tips that can be given. And I would say, honestly, this far down the line, if that's something could be replicated in bigger services, I think it would be wonderful. It's somebody neutral, it's somebody there to listen, it's somebody to give them tips. She follows up with the staff. You can have online consultation if you want. I mean, it's not the be all and end all, and we have managers have responsibility, but just, you know, if it could be replicated, it's money well spent. It is money well spent for the staff, because they've been through the mill.
Yeah.
Staff have been through the mill with COVID. We're coming out the other side now to extreme deficits, particularly in maternity, I have to say, and the staff are going to travel again. So what I would say to you, we have to pay clear heed to it, not just and release the staff and make sure that they get whatever is available to them. But it is central and front and central to everything we should be doing as managers.
Yeah, no, well done.
Hi, my name is Gráinne Walsh and I'm in the INMO. It's great to see all the positivity here regarding wellness, and those programmes are greatly appreciated. But I suppose, and it's been acknowledged, the health service at the moment, the staffing levels is very, very difficult for staff to engage in these programmes. It's a health and safety issue. What I do think managers can do is zero tolerance on violence and aggression in the workplace. We know that nurses are attacked verbally, emotionally, sexually and physically. 68% of the last survey that we did, nurses had some kind of abuse. So what we do need is a zero tolerance approach. So too many nurses accept it, and then a lot of the time when they report it, too many nurses are told, but sure, look, that's the way it is, or they're stressed, or the family. So it is a factor of the environment that they're working in, but you wouldn't expect other people to go in day after day into overcrowded units where the people that are there are stressed because they've been waiting so long, frustrated, that they take it out the nurses. So I definitely think there needs to be zero tolerance on that. And I think nurses would feel supported then, not being asked to build up their own resilience, but that there are managers behind them, and if somebody speaks inappropriately, that somebody comes and speaks to the person that has perpetrated that. So I definitely think that's something that we need to look at. The other recent survey has shown about the incidences of clinical instances. You know, there was 500,000 there recently in the last 5 years of instances. I haven't heard no blame culture being made. That was a buzzword a few years ago, no blame culture. I haven't heard that being used lately. And I actually think that's something we need to seriously look at as well. Nurses are terrified going to work because of the environment that they're going into. They're terrified of the registration. They're terrified if they make a mistake. And then a lot of mistakes have been underreported. And of course there has to be ways of dealing with incidents and clinical instances. But with all the focus now on risk assessment and risk management, which is welcomed and required, the no blame culture seems to be gone. And as I said, a lot of nurses, and our young nurses and our overseas nurses and our mature nurses, you know, no matter what stage of life you are in nursing, so you're moving into the menopause period of your life. We all know what that's like, people that are there. That's difficult, but people are terrified of making a mistake, and they need to be supported when a mistake is made. You need to see, you know, it needs to be managed locally, and you need to also have a look. A lot of the time, it should be a systems analysis is required, and what are all the steps that has led to this nurse making this mistake. And too many times it's the nurse is to blame, and there's a disciplinary process as opposed to an analysis of why the mistake happened. So that's my toughest words for today.
Right. Thank you, Gráinne. And look, we're going to have to call it today, but well done. I suppose for me, listening to the feedback there, which is really important, it's the complexity of trying to release staff and to allow them to attend is hugely difficult for staff, but everybody's trying their best. Psychological support, really, really important. And it's great to hear that you're finding success, as you say, even with a half-time position.
Even after an adverse event, and this
Yeah.
can happen, and it can be particularly harrowing in a maternity setting, that's where that support can also come in.
Yeah.
Managers step out of it, they're new to
Yeah.
support. So I'm just echoing that would be important.
Love that, love that. And then, as you say, zero tolerance to that aggression and the harm in the workplace is really important. I think we all need to push that and have as a structure, an organisation, a system where it's not the nurse that has to then go back in and say, don't be calling me these names or whatever, that they're supported by an independent person. And I say the no blame culture. I think that says it all. If we could get that, we'd be doing really, really well. Sorry, I'm just going to have to go on to our next speech, which is again about health and wellbeing, but I'd like to really thank everybody for a really great discussion.
Yeah. So folks, can I just say that because we're running behind, I have to be gone out of here at 12:30. I really apologise. So we're going to fly through this. It's hard to follow your conversations because I know you're into the energy now of what you want to talk about. So I don't want to go back the way. I left a quiz on your on a few of the chairs to have a quick, just to bring us into the context of. So I'm not asking you to fill it out now. If anybody has had a chance to look at it, well and good. So I'll introduce myself. I'll be Russian Kira. Kate Cassidy is my name. I am General Manager for vaccination programmes in the South East at the moment. I work in health and wellbeing. And just to say, what I'm looking at here is the fact that you are nurses and midwives, but you're also people. So you're a member of the public. And my quiz is about what is killing the people of Ireland. So quickly, can somebody start shouting back, because this is interactive. Heart disease, cancer, stress. But yeah, it's yeah, we go into the stress. Heart disease, cancer. What causes heart disease and cancer? Lifestyle. Who's in charge of lifestyle? But do we all have the same responsibility around lifestyle? We're sitting here in a health promoting room. So have the people who are living in the Sláintecare healthy communities, which are determined by, disadvantage scales, would they have the same opportunity to look after their health as we do? No. So can we say then people are responsible for lifestyles? To some degree. Okay. So the leading cause of death of Ireland, let's fly through here. Okay. Can you see that there? Cancers, diseases of the circulatory system, diseases of respiratory, which all come in under CVD. Okay. You'll get these PowerPoints and you'll send your stuff out. Okay. Okay, so Healthy Ireland talks about how we're going to address all that. I'm flying through here. This is now a health and wellbeing directorate of where we are in Ireland. Chief officer at the moment is your beautiful Grace Rothwell, who's come in to replace Kate Killian-White for a while. And then under that, the yellow there is Derval Howley. And even 4 years ago, there was 4 people working. Now look at this. And I've had a conversation, health promotion officers come in and versus the nurse and the midwife. And, what's the similarities in our work and what's the difference? And I would love if I had an hour here. I would really love. Yeah, and so what we looked at, what Caroline just mentioned there was the social determinants of health. Believe it or not, where you live, work and play has a much bigger impact on your health than your health service. So when I started off a good few years ago in St. John's and in Escorte, health was health. I often tell people, I didn't come in a parachute. I worked in University Hospital Waterford for years. Now, one of my biggest jobs on night duty as a student nurse was to count the amount of people for boiled eggs in the morning. I was really challenged. As I sat over this solid fuel nearly cooker for the night in a beautiful kitchen, okay. So that was the challenge I had, was counting the boiled eggs in the morning. And when I started getting wrapped up in ropes and strings in ICU at 5 o'clock in the morning, when the dynamic changed to arterial lines and whatever, it was time for me to move, but I'm not saying it's time for anybody. I'm so glad you're so committed, you're all still there. I wouldn't be able for it now. But what I'm saying is the whole dynamic has changed. It was a beautiful meaning and purpose role that we all had those years ago. Now it's so changed, that the stresses and demands and incidents and everything we're doing. But it's not the health service that determines how healthy we are. It's where you live, work and play. So for instance, if you are living in a high-rise building down near the Bridge Hotel, you're a single mother of 3 young children, are you going for your 30 minutes of physical activity most days of the week? Are you going and getting your punnet of strawberries? Or are you buying a packet of biscuits to feed the children because you're on a low income? So we just need to remember like where our health is managed. So that's the social determinants of health. I love this slide, public health achievements. I need somebody to update it. If you go back to the life expectancy of people, what's the life expectancy of men and women now? Okay, so all those years ago, there back in the 1900s, it was 47 years, right? Now remember this, women are sicker, men die quicker. How many men are in the room? Please. Now, do you know why that is? Now, I mean, please forgive me because I do enjoy my work and maybe I'm not always politically correct, but right. Why do men die quicker? The what? They just can't bear the idea of being sick and having to drag around like that sick woman. So women are sicker, men die quicker, okay?
Men won't access healthcare as quick as women, maybe. That may be a factor.
Yeah, so I have here in front of me, because I'm switching around my presentation because I need to be gone. Recently, so in 2018 we did health checks and we used an outside organisation. 2020 we did health checks using an outside organisation. This year, because the vaccination programme is scaling down and scaling up, when we scale down we use our nurses to do health checks for healthcare workers. So I took a snapshot of 100 of this year's health checks that we have done. We go to the home health first because they don't have the same access to go and take the blood pressure that you do. So we reach out to people. We have taken a snapshot of 100 people. Out of 100 people that we did a health check on, we had to refer 48 straight away for GP, right? Okay, so 27 people had a high blood sugar out of 90. 35 had high cholesterol, okay? And 22 high blood pressure. No, that were not known of. How many men were in that screening out of the 90? 2. So why are men sicker and women die quicker? Or the other way around, women are sicker, men die quicker. Because we get diagnosed, we go on the hypertensive drugs, everything. Men don't. So that's why men die quicker. They just drop with the CBD stuff. Yeah, and we hear about it all the time. And women develop heart disease and the cancers 10 years later because the men, it's just our hormones protect us for 10 more years. So you get this 60-year-old woman presenting to the emergency room versus a 44-year-old male. Do they treat that 44-year-old male different than the 60-year-old woman? Yes. She doesn't get sent for her ECG the same way the 40-something-year-old man does. She doesn't get sent for the angiogram because they put it all down to other conditions. And because our breast tissue hide what's going on in our heart in an ECG, we don't get sent on for investigations. We know that. That's what's out there. So that's not what you expected to hear. So the leading cause of premature death, tobacco use, poor diet and inactivity, exactly what Caroline has said. So what do we do in the South East? Making every contact count is really good. So if you come for a health screening, you will get that intervention on the grounds that, guess what? Telling people what to do doesn't work. Did you know that? So why is telling everyone what to do? You have to pull the information out of people as what they can do. So that young woman that I spoke about just down living in an apartment up in Bridge Street, look, is there any point in telling her to go for a swim at 7 o'clock in the morning? Especially if she doesn't swim, like. This is what I mean. So we find out from people what they can do, not what we think they should do. Because if telling people what to do worked, I'd be standing up here a different looking woman, all right? And that access to substance misuse that you spoke about, where can you get tuned? Anyway, moving on. So, there's always exceptions to the rule, okay? And my main area was smoking cessation until a few years ago. We have the most fabulous pregnancy project with the midwives down here. We have done so well in the South East that we won the HSE Quality Award. Over 180 beds, and Eleanor from Wexford, been phenomenal. Over 180 babies born smoke-free. We know you give a child the best start in life in the first 5 years. That programme does it. You take 2 parents out of poverty, you're going to give a child the best start in life. You take them out of all those chronic conditions that we know are associated. So making every contact count, so useful. And remember, life is 10% what happens and 90% how we react to it. Okay, completely. I'm not going to mention that R word that Caroline mentioned, because I don't expect you to bounce back when you have all these adverse events that go on. This whole idea of that, 30% are resilient coming out of concentration camps. What does that mean? Like, what does that mean? Like, hit me again? I don't know. So remember, stress. If you see anything other than 2 dolphins there, go to lunch early, okay? And this, sorry for the 3 men in the room, this is the difference between men and women, okay? And remember, it's easier to stay well than to get well. And that's really, really important. Okay, I had the video of the HSE Excellence Award, but I haven't time to show it to you, but you'll find it online, okay? Thank you very much. I am running and I'm so sorry.
Well, wasn't that brilliant? Do you want to give her another round of applause? Now, even though I say it myself, Kate was brilliant at making us all laugh, but we're now going to talk about fitness to practice. So, we have, any organisation that exists to deliver statutory functions if you're in the public service. And one of our statutory functions is to set the standards of behaviour and attitudes in the workplace as professionals. If, however, those are seen and deemed to have been dipped under the acceptable threshold, we do have this responsibility then to consider complaints made about registrants and investigate. Or indeed, we have additional powers that my colleagues are going to talk about now, where we feel if something's vexatious, we don't even have to do it anymore. These are new powers. Registrants, when we engaged with them in 2019, and I'm sure before that, but we got solid evidence in 2019, said this was, well, A, it was the thing that everybody knew the board about, which is awful. But secondly, people just felt very disenfranchised about processes if they got involved. And this was not only just the registrant, but witnesses and all parties to the process. So we have gone on a journey about understanding the perceptions of our interactions with people, and we are trying to make it better. It's still a statutory function we'll have to use, and it's appropriate. And indeed, to be honest, and very cruelly, I suppose, our colleagues in the UK are going to be heavily criticised because they didn't pursue Lucy Let Be Better. So it is a thing that we must do, and we do move very quickly. Louise is the president of the board, and if we get told about a registrant who is seen to be really dangerous for the public, we move immediately to suspend. That doesn't mean that there's any, we haven't made any decision about guilt or otherwise, or the allegations, but we will immediately suspend. So we do that, and we do move quickly. But the whole process is like a black hole of Calcutta to people. So we thought we just need to deal with it, and we need to talk about it, and we need to give people the information that we have. So our colleagues are here today to do sterling work, absolutely brilliant work in the fitness to practice section. And we are endeavouring to become more empathetic to all the partners in the process. And in doing that, we wanted to give you an update as what we're endeavouring to do and the steps to success we're trying to take. So, John.
Thank you, Sheila. So my name is Jeanne Tarrant, and I work in fitness. It's all right, I can find it. Do you know what's on line for the video if you want? Yeah. So I work in fitness to practice department. You've heard a little bit about the registration, and you've heard about our state of the register. We've touched upon education, and I'm going to talk about regulation. And I know every time I go somewhere, everyone's interested in regulation. I can't follow Kate. She was brilliant. So I'm going to try and do my best here. My plan is to talk a little bit about our trends. Sheila's talked about one of the case studies I'm going to touch on. I was going to talk 2 case studies. And I'm also going to talk about our compassion project and how that feeds into fitness to practice. Use this one. Right, so what is the purpose of regulation? It's about setting standards and upholding professional standards. It's about protecting the public, and it's not just patients, it's about every member, ourselves, because we are the public, but also anybody outside. And we do protect the title of nurse. So nobody can use that title unless they're registered with the NMBI. And it's about maintaining the confidence in the professions of nursing and midwifery. And we do that not just through the education, but also through regulation as well, and education and registration. So I want to show you a little video that we're doing because we feel it's really important for people to understand our processes. So we'll be doing a series of videos, and I'm going to just show you a video before I talk about our process when a complaint comes in. Thanks. Please work. Yep. No sound.
Okay. Apologies.
Yep. That's all right.
NMBI considers an
Oops. So
we'll get there.
To protect the public, NMBI considers and investigates complaints about the fitness to practice of registered nurses and midwives. We receive complaints from members of the public, employers, healthcare professionals, patients and service users, and other nurses and midwives. Complaints can be made on a number of grounds, including professional misconduct, Poor professional performance. Non-compliance with a code of professional conduct. Failure to comply with a condition, undertaking and/or consent. And others outlined in the Nurses and Midwives Act 2011 as amended. If you are concerned about the behaviour, conduct, practice, or health of a registered nurse or midwife, or you are aware of an incident or incidents involving a nurse or midwife that may have compromised a patient's safety or the protection of the public, you can contact NMBI at complaints@nmbi.ie or write to us at PPC Division, Fitness to Practice Department, Nursing and Midwifery Board of Ireland, 18 to 20 Carrisford Avenue, Blackrock, County Dublin. If you wish to make a complaint to NMBI about a registered nurse or midwife, please provide the full name of the registrant, their PIN number if known, and the specific allegations that you wish to complain about. The allegations that you wish to complain about must be directly attributable to the registrant you are complaining about. If you wish to make a complaint against more than one registrant, you must submit a separate complaint about them. NMBI cannot investigate complaints against doctors, healthcare assistants, or any professionals other than registered nurses and midwives. NMBI also cannot investigate complaints about the general provision of care provided by a healthcare facility, such as a hospital, nursing home, or other care centre. If you would like more information, please visit our website www.nmbi.ie to learn more.
So a complaint's been made, what happens next? The team, the preliminary proceedings team, will look at the complaint. Under the amended act, and that came into force, it was enacted in 2022, January 2022, the CEO, that is Sheila, now has the power to look at a complaint and deem whether it's frivolous or vexatious. Sheila has passed that responsibility on to our team, the preliminary proceedings team, who can look at the complaint and look at the facts within that complaint. Is it a frivolous or vexatious one? And one of the complaints that tend to be frivolous and vexatious tend to be complaints that have to do with family and money. It's amazing the amount of people who complain about a nurse when a will is involved. So those are disregarded. It goes nowhere. The nurse is advised that, or midwife is advised that a complaint has come in, but it will go no further. That complaint is dealt with and put aside. There are other complaints that come in that the preliminary proceedings committee, and this is a committee made up of nurses and lay people who will consider that complaint and decide whether there's enough in that complaint to put it that there is no case to answer for the registrant. Or they may decide that there may be a case, but they don't have all that information at hand at that time. If it's the latter, they would then refer it on to the team that I work in, and that's the Fitness to Practice team. And we work with the Fitness to Practice committee, and again, that's a lay majority. It does have registrants within that committee. And working with us, other people to look at the investigate the complaint, we will try and get witness statements, other documentary evidence to see whether there is more to this complaint. The team, and that is the committee, will, having regard of the complaint, will decide whether the registrant has to be invited to an inquiry, and that's a hearing into that complaint. They will make a decision, and what I'll do at later points of my slides, I will talk to you about what happens between the Fitness to Practice committee and the board, because at some points there's some complaints that can be dealt with much earlier before going to an inquiry. Once the Fitness to Practice Committee have looked at the complaint, have heard the evidence against the registrant has the opportunity to put their case. The committee may make recommended sanctions, or they may decide that there is actually no case to answer. If there is a case to answer, the committee would have put sanctions, would make recommended sanctions, which will then be sent to the board. And the board would look at the sanctions that have been recommended, will either accept the sanctions as they stand, may decide the sanctions are too harsh and reduce the sanctions, or decide that they're not enough to reflect the seriousness of what the registrant has done. Some sanctions are confirmed by the board, and other sanctions, the higher level sanctions, like your cancellation, need to go to the High Court for confirmation. So that's our process. So I'm now going to give you some trends. Preliminary Proceedings Committee data. And what so you'll see here, and I want to point you to 2017. And the reason I point you to 2017 was that was the highest level of complaints that we've received at the NMBI. And the reason for that was that the Act was amended at that point. The 2014 Act was amended to allow members of the public to make complaints. Prior to that, complaints were coming in from employers and other registrants. And you'll see that over the years, since 2017, that the numbers have reduced. And the reason for that is as people get used to making a complaint, realizing that a complaint can only be made of a registrant, someone on our register, that word has got out, and so the levels have dipped a bit. Now, you'll note that in 2023, we've had 51 complaints to date, and that's as of July, but we expect that that number will sit around the 60 mark in the next quarter. So we do get a fair number of complaints, and this is what the PPC, they'll look at the complaint, they'll decide whether there's more to the complaint and therefore needs to be referred to our department. And I'm going to give you a very, very busy slide here. And that slide shows that the decision making and the numbers of the decision making. I'd like to have you look at the total number of decisions, and that's the green column. And then I want you to focus on the purple column. And if you look at 2019, that's number 77, so that purple column, and that's the number of cases where no further action was required. These are cases that the PPC have looked at in its entirety and decide there's no further action. So the registrants are informed that, that there's no further action, there's nothing else they can do, and that's the end of the matter. I then want you to have a look at the orange column, and that's the number of people or registrants that are then referred for further investigation by the Fitness to Practice Committee. And you'll see that although there are lots of complaints coming into the NMBI, the numbers actually coming through to fitness isn't that great in comparison. And if we focus directly onto 2023, you'll see we've had 35 complaints as of the 29th of August. 40% of those complaints of no further action decisions have been taken, and 51% of those complaints have been referred to our side of the house. One of the things I said earlier that we're trying to make the process better, and under the amended Act that was enacted in January 2020, the Preliminary Proceedings Committee now are able to accept undertakings. So what is an undertaking? An undertaking is an agreement not to do the act or actions that led to the complaint. And it can be something as simple as agreeing to work within your scope of practice, or not working within a certain area of practice, or even conditions being put on your practice, or taking a course of training in your practice. So what we expect to see, that 8.6%, that in time, that number will climb, because there are some complaints that can be dealt with undertakings. Not all, but there are some complaints that can be dealt. And if we can deal with those complaints earlier, it makes a huge difference to someone's life. Now, looking at our activity, you'll see our highest level of activity was in 2022, where we had 38 complaints over 70 days and of those, 30 inquiries were completed. This year, we've not quite got there, but we think that towards the end of the year, that number will go up a little bit, because we've got a number of inquiries coming through the pipeline. One of the things you do have to note, that the number of inquiries do not relate to the number of days, because some inquiries will take long and some inquiries will take short. On average, we're looking at over a 2-day period. So, spoke a little bit about undertakings and consents, and just to give you a sense of what they look like. So since January 2022, we've managed to conclude 7 complaints by means of undertaking. We know that the message isn't out there yet, and we're hoping that talks like this will get the message out that if you are referred, and if the complaint isn't serious, or all complaints are serious, but there is within that complaint that there's something there that shows that you've got insight, you may have already undertaken training, you may have already put things in place, that you could make an offer of undertakings to the preliminary committee. Now, for the inquiry team, undertakings have already been part of the Act and have always been part of the Act. But since January 2022, 6 have been concluded through undertakings. We expect again that number will increase as time goes on. But in truth, what we expect to see is that the number of undertakings at inquiry stage to be less than the number of undertakings at PPC stage, because we hope that the numbers coming through, that if an undertaking is going to be accepted, it will be accepted at PPC stage, it's more likely, and that by inquiry stage, it means that only the most serious of those complaints need to be dealt with by the Fitness to Practice Committee. So why undertakings? Well, it does save time and money, but the most important thing for me is that it does reduce stress on the registrants. We know that registrants that are under the shadow of the investigation for their practice are less likely to be working. They may choose not to work in the profession. And if we can get these people back into practice earlier, it's beneficial to them for their health, but also to the organisation that they've been removed from. So the important thing is that getting the message out there. There are some complaints that can be dealt with through the undertakings. So, looking at the number of the types of sanctions, as I alluded to earlier, the highest level of sanction is cancellation. And to date, as in July for this year, only 2 registrants have had their registrations cancelled. It's important to note, when I know some of these cases, it tends to be really, really serious allegations against the registrant. It also tends to be people with serious health issues that have their registration cancelled. Then you have a combination of sanctions where you have suspension and conditions include agreeing to have training or not working in a certain area. So there may be some registrants who, depending on what the allegation is, are the condition put on their practice is that they don't handle controlled drugs, or that they are not, won't work in a particular environment. And then you have the censure and conditions. Now, censure is, I suppose the plain English term is a telling off, but it's much more than that. It's very serious, because these conditions will be notified to the employers. Then you have your censure and a fine and admonishment and advice. And you'll note there that at the moment, no registrant who has had a sanction imposed on them has had an admonishment or advice. So I've talked very briefly about trying to support registrants. So what else are we doing? Well, in November 2021, a report was commissioned by the board, and one of the things that came out, and this was an ex-board member, Martin Higgins, who did the report for us, and he said that we need to move towards a more compassionate complaints process, that we need to work smarter, we need to do it quicker, and we need to explain it better. So what do we mean by that? So, as I said before, we're using the Act to enable us to resolve cases earlier in the process, so earlier resolution of cases at PPC stage. This is where complaints that come in that are frivolous and vexatious, we don't have to spend time looking at them, we don't put the registrants through stress, where undertakings can be offered. What we're also trying to do is streamline the inquiry process. So one of the things we've done is to bring in-house our scheduling process. So we now talk directly to the registrant and all their reps to try and schedule the inquiry as soon as we can. We are developing feedback mechanisms. So one of the things that we're also doing is at the end of the inquiry process is asking the registrant, the subject of the complaint, our witnesses, how did we do? What could we do differently? And hopefully in time we'll be able to share that feedback with you. We want to, and we are, simplifying our communications with registrants. So one of the things that we've started doing in the past, when a registrant has been referred to the fitness to practice side of the house, that was that they didn't hear anything else until they were told, oh, by the way, there's an inquiry. What we're trying to do is throughout that process, while the investigation's ongoing, that we inform the registrants, this is where we're at, this is what else we need to do. We're trying to make sure that our written communication is done in plain English. Now, it's very difficult to do plain English when you're having to put legalistic stuff in the document. We have to tell them what part of the Act we're using to contact them, but trying to make it in as plain English as possible. And as a team within the department, we will all be attending a plain English course in the next couple of months. And as I said, we are providing as much more information throughout the process as possible. We're providing as much updates as we can, and we're trying to support witnesses because we know it's not just the registrant who's the subject of the complaint that has stress throughout this process. We also know that those registrants who are witnesses to the complaint will also have some stress. And we're trying to support those witnesses as well, by providing as much information throughout. We're updating our web content, and you've seen one of our first videos. There'll be another video coming out soon, which explains the inquiry process, and we'll be doing other videos, trying to make it so that people can find that information without waiting for us to tell them about it. Another thing that we'll be doing in-house, and certainly within our department, is trying to engage with stakeholders much more. I had the pleasure of being invited to a hospital to talk about the fitness to practice process, and it was really nice to be able to explain and demystify what actually happens. So we want to do more of that where we can. So what are we doing to support? As I said, we know the process is really stressful. So what we've launched an emotional support care line, and that was launched in July of this year. And it's a free number, And it's there for self-referral. So anybody who's involved in the fitness to practice process, your registrant, the subject of the complaint, the witnesses, the complainant themselves, members of staff who want to talk to somebody who's independent outside of the process can contact this number, and they can talk to somebody who is trained. They're qualified counsellors, and it is an Irish-based service that they provide. One of the things that the service also provides is that if they feel the person needs more support than they can offer, is they can advise the person they're talking to where else to go, but they also have in-house counsellors that they can offer proper counselling to individuals. Okay, so that brings me to my 2 case studies. Sheila has touched on one of them. So what happens? The first case study I'm going to talk about is where you have your what I call low-level individual whose practice is a bit iffy. Things have been put in place. There've been professional development plans been put in place. You've tried to support them through OK Health. You've done everything that you can, but this person's practice still leaves a cause for concern. What do you do next? You've involved HR. You've involved everybody within your organisation. Where do you go next? Well, our advice is pick up the phone, contact our PPC team. They will advise about what you need to do. It may be that the time has come that you have to refer because you're concerned about their practice and about their impact, potential impact they could have if they did something terribly wrong. So talk to our team. We can advise. And then you have the other extreme, and that's the Lucy Letby case. What happens? What would we do? Well, first of all, something like that, if it hits the media, within our department, we'll convene a board meeting straight away, we'll involve Sheila straight away, and a board meeting can be convened as an emergency. And that board meeting is to look at the facts. Is there enough here? Is there such a concern for the public? Do we have to protect the public right now? If that's the case, they could do an emergency suspension. But it could be that the registrant could offer undertakings. So again, you could have undertakings at PPC stage, inquiry stage, or at board level where consideration's been taken. Is it appropriate to have undertakings in that case? That will be considered by the board. It's not always appropriate. Could the person offer that they would, and this is where the undertakings, that they would choose not to work, that they will take themselves away from clinical practice? The board has to be satisfied that what the person is offering is the right thing, that it will protect the public, and it will give the individual space to consider what is happening, because people need time out. If it's that serious, if the board decides that the person should be suspended, then it will go to the High Court, and the High Court will be asked to confirm that sanction. But that's what the NMBI has done, I've witnessed it, and can do. We are there to protect the public. We have to be satisfied that that individual, whatever they're going to do, is not going to be detrimental to the public. And we have to uphold those standards, and we have to protect the reputation of the professions. And I've come to the end of my talk.
Thank you, John. Okay, so I want to bring Louise in here because we're the administrators of this, and I am effectively the prosecutor, if you like, as the chief executive for cases. And it's a very expensive process. It's a very litigious process, and it's very sort of tied down in, the highest standards of adversarial legal practice. So for every hearing day. Now we're driving down the cost of it a wee bit because we brought in a panel of lawyers, but it's about €60,000 a day for a fitness to practice hearing. We spend over 2 million a year on legal advisors. So it's a hugely expensive thing to do. We have to do it for for people who are flagrantly abusing their professional standards and are bringing potentially the professions into disrepute. But the more we can mitigate and the more we can upstream intervention and improve practice, because we totally believe it's like sort of politicians. Nobody intends to get into trouble as a politician. You meander into it, and nobody sets out, I'm sure, as a nurse or a midwife as they started their profession to finish up in that position. So it's if we can find and all this well-being and you're looking after yourself, it's a huge issue because we as employers and in the bigger system need to see where problems are potentially occurring, where weaknesses are being identified, and try to upstream it, because the earlier we can intervene the better. But we do have open phone lines now that people can connect with us about if they have concerns about a member of staff and how they're behaving, etc. But I think Louise needs to give us the final word on this, because it is one of the biggest and most difficult things for the board members to do. So the PPC and the Fitness to Practice committees are big. PPC is what, about 11 members? So some of those are lay people. And some of them are lay people and lawyers, or lay people and nurses or midwives. And then we have board members who are nurses or midwives, or indeed not nurses or midwives on it. So it's a combination. And then the Fitness to Practice is a big committee, about 33 people. Again, a combination. Has to be 3 people on the panel to hear the case. So they have a big job to do, and then it comes to the board. And then the board have a big job to do. And I think Louise would say, and I'll say it for her, that it's probably the most difficult job as the president of the board, because you're deciding on somebody's future. And of course, then we've got the scrutiny of the High Court, and we obviously want to get it right. We don't want to be criticised in the public domain by the High Court. So it's a really difficult task for board members to do, and it is one of the most time consuming if you're on one of those committees, because maybe like there was one recent inquiry was 12 days long. So it's, so a lot of the people who are retired do it because they can find the time, and we need them to be standing forward to do that. But I think, Louise, maybe I'll stand down now and you finish off on this, but I think it is one of the things that board members take very seriously, both the lay people and the registrants that are on. And, I think, again, as a wider sort of pitch, we're always looking for people that would be willing to go on the board, but they do have to understand this huge responsibility that comes with being appointed to the board. So with that, I want to hand the hand grenade over to you.
Okay, thanks, Sheila. This wasn't on the itinerary, but before I sort of close and add my piece as president, does anybody have any question, query, or feedback to Jan, who's given us an excellent overview, which is the most expensive part of how our registrant money goes, but it's only a very, very small amount of registrants that go through Fitness to Practice. So I heard that narrative of, nurses and midwives are afraid to practice. But does anybody have any questions for Jan around this lady here?
Just wondering, in terms of quantifying complaints as a referral, would you please slide this many came from the public, this many came from the organisation or register?
So what we're hoping to do, which we haven't yet done, because we've only just digitised our processes, the registration department are very lucky they've digitised a couple of years back so they can pull the figures. We're hoping to do exactly the same. There'll be a state of the fitness practice document, hopefully in a year or so, because it was only in March 23 that we digitised, so we'll be able to pull that data and compare.
Yes. And in terms of the parallel process, so if you have in our organisation, we have the trust and care, and then obviously we have the RD and et cetera, So if there's parallel things going on, if practice is on hold until those are complete, or just talk through that?
So it depends how serious the allegation is. So if it's really, really serious, even though if the guards are involved and it's a criminal matter, we stop and we pause our process. But if it's a trust and care, a decision has to be taken. How safe is this individual? Is this person still safe to be in practice with conditions? or should they be removed from practice while the trust and care is completed? So generally what tends to happen, there'll be a lot of liaising between the PPC team and the person making the complaint to see where they're at, to make sure that we can be satisfied that the individual being complained about is safe to practice. And sometimes it's a judgment call, but very rarely do we start our processes while the trust and care processes, because it may be that the trust and care, having looked at everything, finds there's no case to answer. But we may find that there is something in that person's practice, or we may not, but we very rarely will do that. So there's a lot of communication between the two, complainant and our team, having that conversation to be sure.
All right. And there's another question, another two questions. This lady. Yeah.
Yeah. So just if somebody has sanctions to their practice, is that person themselves obliged to inform their employer?
Yeah.
Or does NMBI inform their employer? And if they change employment, who informs their employer?
So it's exactly that. The person who's had conditions placed on them or a sanction have to inform their employer, and our department will also inform the employer. If the registrant changes employment, they are obliged to inform their employer. We very rarely do we have employers contacting us. We can't give information out. So if the registrant advises us that they've changed employer, we'll let the employer know with the registrant's permission. But at the point of being sanctioned, and if they're in employment, the employer will be notified at that point.
Okay. Any other questions?
I just think that this is really, I'm a director of nursing in Wexford General Hospital, Eleanor Carpenter. Sorry to introduce myself earlier. I just think it's really important that we're getting this information on our fitness to practice. It's probably one of the most stressful things that you deal with as a director of nursing or required any nursing. I think that there's a lack of clarity around what conversations can be had before taking that plunge into fitness to practice. There's the fear of the fitness to practice process. There's the fear of not reaching your duty of care to the public. And I think with the more Lucy Letby case now in the UK, maybe that would become even more keen for people. I think that the number of cases could be significantly reduced if there were two-way conversations early in the process, because we would get a lot of advice, I suppose, from HR, but HR departments can be notoriously working in the grey area. You really don't, and the more information and the more discussion we can have with people who exactly know the process, or what's like particularly if you can go for undertakings, that's, and that's not something that I suppose, like at this stage, obviously you've been working very hard to get somebody to undertake certain things, but it comes differently maybe when it's, without having to go the full sanction. Is there anything in between? And I think it would reduce costs hugely if we actually knew how to communicate.
Certainly, and that the message that I'm giving out today is, if in doubt, ring our team. If in doubt, ring our team. Because there are the grey areas. As I said, there's that low-level individual that you've supported. It's coming up to maybe a year. You realise, you're looking back, that it's been 3 years, that you've been trying to keep them in practice, that you've done everything in your power. Talk to our team. That's what we're here for. And certainly, if we can't advise, we'll know somebody who can.
And you see, that's something that I wouldn't really have felt that, okay, I can pick up and have a conversation with fitness practice person around this. I would have thought, well, this is
starting a process
type of scenario that I don't know where my boundary is. So it's very welcome.
Right, thank you. Is it this lady?
It's very easy. There are undertakings in service with the staff member, and they're medium to long term. Should that be blocked, then is there an onus on the organisation or the employer to let them know that there are undertakings with the staff member, for example?
So I must stress that the word undertakings, that the way I use it, is a legal term. And I know that you can have undertakings in employment. So the legal term that I'm using undertakings for, it's a legal agreement between the registrant and the nursing board to say, I agree to do X, Y, and Z. I will do, and it's time bound as well. And so things like, I would agree to do training in drug management, medicine management, in 6 months. I agreed that I won't work with vulnerable adults until I've done this, or I'll never work with vulnerable adults. So it's a legal basis, and if the registrant breaks or doesn't do what they've agreed to do, they will be referred back to the board, and the board will then consider whether look at whether they should be further investigation and whether they should cease their registration. So it is a very legal term.
Okay, thanks. So if there's no more questions,
we finish. I have an ask. I know many of you in the room are educators. I know many of you are clinical practice coordinators. We're desperately short of expert witnesses, so I'm putting it out there. Please, 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 please go onto our website, look at expressions of interest, and put yourselves forward. Please, please.
Okay. Thanks, Jan. There's no such thing as a free cup of coffee, is there? No, I think that's been a really useful session, and as Eleanor has pointed out, just knowing that you can reach out, whether it's for registration, regulation, or education and training. There's a full team of very expert, very accessible, and very open. And it's important to note that we are there not just to regulate, registrate and educate, but also to support and advise. And I think the Compassionate Project and the undertaking and the move to try and quicken the whole process is in reflection of the feedback that we've been getting. So, just going back to where we started, what we're about as a regulator, I'm a nurse. We're all nurses or midwives with regardless of any. It is all about public protection. There are the three pillars from a regulator of our professional body: regulation, registration, education and training. But we have such an important role to do collectively. And in no particular order, or in reverse order, I think the practical advice that Jan has given us has been very, very informative and very useful. And the changes that are very evident within how we are actually doing what we're doing within the board. Indeed, Carolyn and Kate, let's just say it was insightful, because mental health and well-being, or health and well-being, is on everybody's agenda, and whether it's resilience or whether it's, what was the saying Kate had, women get sicker and men die quicker. Anyway, it's a good job we didn't keep her any longer, we would still be laughing. So, it's been fabulous to have that focus on health and well-being and bring that back to your relevant areas. The opportunities, education, what's on offer here with regards to in your local CNME through Ciara and supported with the educational role nationally. It's very impressive, and the uptake and the positivity that's been felt. It's a standout for me how well you're being supported here in the South East, and that is so important. So it's important to acknowledge all the positives. The quality initiatives for this lady, I didn't catch her name, from midwifery, Paula, and the clinical psychology and the clinical skills facilitator and the actual benefits of CPD need to be, to the fore. But there were challenges mentioned, and this is not just about patting each other on the back, but actually going back and saying, well, what can we really actually do about this? So we've heard the challenge about the application process of overseas. We're constantly working on that. And if Ray was here, he'd have another narrative with regards to that. The staffing levels are and will continue to be a problem, because the state of the register, as Cathy Ann has outlined, is a live register, albeit self-declaration of where we are going to have gaps, where we have gaps, and where we can actually retain and recruit. Certainly violence and aggression, risk, and how we actually adopt and go back to that zero tolerance with regards to, misconduct, assault, verbal, whatever, physical, and the no blame culture. So certainly for me, the future proofing of our profession of nursing and midwifery lies within our hands. Lies within our hands collectively, because it's only through us partnerships in practice that we're actually going to actually fix what's wrong. We are doing a fantastic job. and we don't say it well enough and long enough ourselves. But the focus really needs to be on the recruitment, on the retention, and on the reflection of the feedback that you've given. So I want to really thank Ciara and Roisin and our team from the board, Cathy Ann and Jan and Carolyn and Kate. But most of all, I want to thank every one of you that took the time out to come this morning and to listen and to engage, to network. And I hope I've met a colleague that I trained with in Kappa in 1993, Susan Hennessy down there. So it's so important to get out again, and hybrid and simulation, and it's all great, but you can't beat the face-to-face. So thank you all for coming today and for sharing your reflections and your feedback, and it's given us lots of food for thought, So we want to acknowledge the warm welcome we've got in sunny. I know you're flying out the door, so have a good day and safe travels to wherever you're going.